Good evening, good morning, everyone. I'm calling in this today from Guatemala City. My name is Greg D'Alessandro. I'm going to try to do my best Brian Morales impression this morning. This is the Global Coalition to Address Synthetic Drug Threats, session 3.1 for the West, and the date is August 14th, 2024. I'm pleased to share with you some administrative announcements as we kick off the final sub-working group session of the Global Coalition. I would like to start by thanking our co-chairs, Inga Dora, Carolina Bruce, for all of their work over the past 11 months. It has been quite an intensive program, and we are very grateful for their dedication. I would also like to thank our international organization coordinator, the coordinators, Pamela Patino and Wadi Malouf. They have been great collaborators over all of these months, and we are very grateful for all of the support they have provided across the coalition, including helping us identify speakers, organize these calls, and advance the coalition's work. Today's theme for the coalition are those of evaluation and transition or sustainability. Now, what do I mean? Now that we are coming to a close of the first year of the coalition, given the diverse membership of the coalition, we need to look at how we transition to a new phase that is more manageable and easier to organize. We come from so many different backgrounds, so many different professions, that to really start to make progress at the next phase of the coalition, we need to find a way that we can manage the work better. I think in the second year, our success will be measured very specifically by the outcomes of the actions and the initiatives that we are going to undertake. So I will discuss them in just a moment. Okay. First, I would like to cover some of our accomplishments to highlight just how far we have come in the past 11 months. The ministerial meeting that launched the coalition took place over a year ago, July 7th, 2023, and it demonstrated high-level political commitment to address synthetic drug threats that was a call to action by the top leaderships of our countries. That high-level interest really instilled in us a sense of urgency, a focus that has led to the very productive meetings that we have had over these past 11 months. The slide outlines some of these accomplishments. Excuse me. We were able to develop a network of over 1,600 government representatives from 158 countries. We are all united with this common purpose to find practical solutions to address these threats that are manifested by synthetic drugs. In total, by the end of September, we will have engaged in 148 hours of virtual meetings with interpretation over the past year to understand the problem, to exchange experiences, and to share opportunities and discuss new ideas. In May, we worked together to identify 68 recommendations across all of the sub-working groups. We had in-person meetings with co-chairs in Italy for Working Group 2 and in Greece for all the working groups. And these working groups, we discussed the various priority initiatives. There was a realization from those meetings that this issue is going to require continued and intensified cooperation, as well as funding and resources for many years to come. This is not something that is an acute issue that is solved quickly. It is a chronic issue that is getting worse, that requires the attention of the international community and new responses, new ways and new strategies of addressing that drug phenomena. To summarize this slide, what we have done this year, we focused on building our car, building that infrastructure. But now comes time to start utilizing it. We need to start test driving, and we are ready to start moving forward in these initiatives. It has taken a year, but it is the scope, the intensity of our work, the extensive nature of the subjects that we have covered that really did require so much intensity that the nearly 150 hours of these Zoom calls. I really want to once again thank sincerely all of your dedication, participation, and endurance for what I know was a lot of time given everyone's busy schedules, but it was a meaningful exercise, and we very much appreciate your collaboration. Next slide, please. We have established new networks as a result of the coalition. On the health side, developing the Global Recovery Network, the Global Women's Network, and the International Consortium for Alternatives to Incarceration, or ICATI, which will help move people from the criminal justice system into community-based treatment services. And we have a new network that will be coming in the future, INLAD, the International Network for Legislation on Drugs, to help fill some of the legislative gaps that we are finding. Overall, we also have been raising awareness of initiatives, 120 initiatives that have been promoted by international organizations. This is a great library, a great resource that the international organizations, 15 of them, have provided us. It includes everything from intelligence and information sharing platforms to training programs and capacity building opportunities. We have seen that coalition participants have used these initiative pages that we have set up on our website to express interest to the international organizations in these activities. I would like to raise the issue of donors. Here I'll mention INL. We have referred to these to these initiatives for developing funding packages over the coming year. We are looking specifically at about 30 initiatives that we will want to support from that many of the initiatives for the coming year, and have really oriented our programming in INL at the U.S. Department of State to support global coalition initiatives almost exclusively for the coming year. Next slide, please. So what is left to accomplish? As I've mentioned, we have built the car. Now we need to drive it. We need to operationalize the actions and initiatives that we have been discussing, both in the recommendations as well as the initiatives page, as well as through the presentations we have been listening to over the past few months. There are 3 lines of effort that we would like to propose going forward in the coalition after September. First is to look at having collective meetings or groupings of coalition partners. One that we are looking at is a donors conference for donor states to be able to coordinate the assistance that they are already providing and to take stock of additional needs that the international community is facing, so we are aware of what we are contributing and what needs to be contributed. Second, we are considering a thought leaders conference. This idea would be bringing together academia, think tanks, but also policymakers, bringing research, policy, and practice together and helping look at a forecast of where the field is going, where synthetic drugs may pose a greater risk in the future, what the patterns are looking like so that we can try to undermine and address some of those challenges that we find internationally. So that is something that we're looking at. We sort of push that off as an activity for another year, for next year. And we can think of other meetings where the coalition may come together. We do not envision that we will continue to have these monthly meetings, but we can have specific meetings at specific times on specific topics. And we look forward to your feedback in terms of recommendations on that front. Second, we are also considering regional meetings organized by international organizations or regional organizations to help us understand the dynamics and have countries and regions come together. We are already looking forward to a Middle East drug dialogue, which will take place October 15th and 16th in Hungary. We're looking at the African Union assembling supply reduction focal points in Madagascar and demand reduction focal points in Tanzania later this year. We are looking forward to Pacific Island meetings, one for demand and one for supply. The Organization of American States is helping us in arranging meetings also for the Western Hemisphere. And UNODC, as in past years, supports the convening of Central Asian drug authorities. And I'm sure there will be other meetings of European governments and or North American governments as well. So the world is coming together on regional forums to look at regional dynamics and how to best address them. And the final point that I want to raise, I would like to say that we're looking at lines of action for the second year. What does that mean? Well, by September, we're hoping to have reports from the sub-working group chairs to the co-chairs to the working group co-chairs. We're looking at very specific and concrete initiatives and actions that we can then form smaller groups or groups of interested countries to then carry those forward as part of programs and initiatives that will go forward. And so if your country or if you as an individual within your government is interested in participating in some of these, the next month we'll give the opportunity to identify those and then join these and move forward. The next slide, please. The website will remain the organizing platform for the work that we are doing. So we will be posting calendars, opportunities, and we will be explaining what these lines of effort and lines of action are moving forward. I would like to give you a couple of examples where we can help illustrate what this might look like. So this first example will be following that red arrow that's on the slide. For example, we can try the legislative network. I mentioned earlier, INLAD, as an example. So what might a year look like for a participating parliamentarian or their staffer? In October, UNODC plans to conduct its initial launch with OAS-CCAD, subsequently launching the pilot program for the Western Hemisphere just a few weeks later. If your government or an individual within your government is interested, you might express that interest to participate in October. This is just for hypothetical purposes and does not reflect the actual plan. We just are trying to show how any initiative or any plan might go forward over the next year. In December, we might have an in-person meeting that identifies priorities for legislative development. For example, it may be class-wide scheduling. That might be something that the legislators might want to take up and share sample legislation on. So from January to June, the staffers of their respective countries could finalize and work with their legislator to introduce a bill. That legislation could be adapted, and we could have an outcome by July or August that would say, this number of draft laws and bills were considered for approval, and this number of laws were passed. So now the drug control architecture is stronger as a result of this program. Another initiative I could give as an example is the generic development of a training program or law enforcement supply reduction for law enforcement supply reduction professionals. And we could identify participants, collect some baseline data, such as what is their success and impact. We could conduct training that includes mentoring and technical assistance, and at a later time have an assessment of impact as the result of the training environment. And that, what I just said, went across the green arrow across the bottom of the slide. These are basic but illustrative examples of what actions and initiatives might look like that we could pursue moving forward into the coming year. You might find one or more of these of interest, so we encourage you or other experts you may designate to participate moving forward. I'm going to stop now and thank you all for your collaboration. It's been a pleasure speaking with you this morning. I apologize for the length of the information I had to share this morning. I will turn it over to our co-chairs, Ingadora and Carolina, if you want to take this. Thank you.
Thank you so much. I think, Alessandro, is that what you go by? D. Alessandro, or?
You can call me Greg, but yes, D'Alessandro is my last name.
Okay. So I think that you have already laid it out for us, what we can do. These meetings have been, you know, that there is something so magical when the world comes together around an issue. And that is what the coalition has been able to create. We may, we know that there's a lot to do. I think that there may be three main pillars that we can definitely agree upon. First, we're not going to go anywhere and in any work without good research supporting our work. Second, as I've read the group, is that we want it to be community-wise, so that focusing on the community and through that to the individual. If I'm saying this clearly enough, so we're taking the responsibility of the young people, and and handing it over to us to say, okay, it's not your idea, but we have lots of other things that you can do. The third key element that we have learned is that it is extremely important for researchers, policymakers, and practitioners to work together so that science can be a base for our work. It's not an easy work. I mean, the kids are all the same wherever they are, but of course we realize that there's quite a difference in our culture. So each community needs to figure out, or if we can work that together, that would be wonderful, to figure out what is best for the future of the next generations in my community. So that said, I decided to bring no slides. I think we're overusing slides, and so uh, I decided to just like talk. So, and my understanding was that we wanted to give the floor to more participants to be able to come up with ideas and talk instead of filling the time with even they have been very good, many of the presentations that we have got. So the floor is yours, unless there are any questions about what I'm saying. As you can hear, I just came back from a vacation. So my brain is still in vacation mode, but it's gonna come back. So Caro, do you want to add something? Or
Gracias, Inga. Efectivamente, hemos visto muchas experiencias en el transcurso de estas reuniones, ¿no? Y hoy día, tal como se mencionaba al inicio, la idea es poder hablar de evaluación y sustentabilidad. Y lo que mencionaba Inga dice relación con aquello. Tenemos que considerar a las comunidades para poder proponer las iniciativas, programas, proyectos que podamos desarrollar en prevención del consumo de sustancias. Solo con aquella consideración y de acuerdo a la experiencia que nosotros hemos tenido en distintos programas que hemos implementado, nos hemos ido dando cuenta que esto que pudiese parecer solo un discurso, ¿no? Que pudiese parecer solo algo que se lee en los libros del ciclo de implementación, de los programas basados en evidencia y de la necesidad de ir haciendo retroalimentación respecto del desarrollo de los programas y los resultados que vamos obteniendo, es algo que efectivamente se constituye en un elemento fundamental para la sustentabilidad de los programas. Cuando nosotros trabajamos en prevención, yo siempre digo que tenemos que tener como un subtítulo grabado en nuestro cerebro, ¿no? Que es que las comunidades tienen que generar sus propios procesos de prevención una vez que nosotros ya no estemos disponibles para ellos. Y nuestro trabajo es hacer que no estemos, que no nos necesiten las comunidades, sino que puedan generar y perpetuar los procesos preventivos que los ayuden a desarrollarse y a ser comunidades más saludables. Y para eso es fundamental poder sistematizar organizadamente qué es lo que está pasando con los programas. Es fundamental poder tener evaluaciones, poder tener un análisis, ojalá desde la academia o ojalá desde algún externo que nos pueda decir qué está pasando. Y es fundamental tener la retroalimentación de las comunidades. Nosotros tenemos que hacer el equilibrio entre lo que nos dice la evidencia y la traducción eh, necesaria que tiene que tener para que esa evidencia sea un discurso que las comunidades asimilen y puedan perpetuar. Entonces creíamos que era interesante con Ingadora poder abrir esta conversación.
Great, thanks, Carol. So, who was first? Mariano? Can I hand the word over to you?
Sí, hola Carolina, hola Ingadora, hola a todos. Buenos días en América, buenas tardes en Europa. Me parece crucial esto de la evaluación, por supuesto, muy, muy importante. Ahora, yo creo que tenemos que también mirar no solo qué pasa con los programas, ¿no es cierto? Y cómo las comunidades responden frente a lo que está sucediendo, sino que creo que también tenemos que ver qué pasa con las realidades. Y creo que hay una variable importante que la tienen pocos países todavía y que creo que nos enlaza, nos comunica con el grupo 2, que es el grupo de información, el 2.1 y el 2.2. Que nosotros somos el grupo 3 y el subgrupo es 3.1, el que estamos ahora. Porque en el fondo necesitamos saber cuál es la realidad, cómo están los consumos cómo están los consumos en las comunidades. Necesitamos saber para saber de qué realidad estamos partiendo, cómo están los consumos de los adolescentes, cómo está el consumo de los adultos, de la población general, porque son esas las realidades que probablemente queremos cambiar. Yo diría, lo primero es que queremos tener menos prevalencia de consumo. Lo segundo es que queremos tener menos incidencia del consumo, o sea, menos casos nuevos que vayan apareciendo cada año. Lo tercero es que queremos retardar la edad de inicio de los que se van a iniciar, porque también es parte de la evidencia que nos ayuda a disminuir los daños si se inician más tarde, por lo tanto también es una buena estrategia. Entonces deberíamos evaluar cómo está la prevalencia, la incidencia y la edad de inicio de los que consumen. Porque eso es lo que tenemos que cambiar en el fondo, en el fondo. Además de eso, otras variables de bienestar u otras variables de riesgo y de factores protectores que también tenemos que medir para verlo todo en su conjunto. Pero yo diría que eso es el indicador duro, el indicador fuerte, y pocos países lo tienen. Y aquí a lo mejor, para ponerlo en la conversación, a lo mejor lo que nos está sirviendo, nos debería servir, son evaluaciones locales, de realidades comunales, de ciudades. Porque cuando queremos cambiar territorios con políticas territoriales, y a veces estamos haciendo estudios grandes, nacionales, que a veces solo abarcan a regiones y no comunidades pequeñas donde realmente ocurren los cambios. Entonces no tenemos el seguimiento de cómo va la incidencia, la prevalencia y la edad de inicio. Yo diría que eso es fundamental tenerlo claro, porque esas son las realidades que queremos cambiar, realidades que mejoren la calidad de vida, mejoren el bienestar de las poblaciones, y dentro de eso es menos consumo, menos incidencia y retardo al inicio de los que van a iniciarse en el consumo. Y posterior a eso, o simultáneo con eso, los programas, cómo se están implementando. ¿No es cierto? ¿Cómo está ocurriendo esa implementación? Que son programas basados en la evidencia, sin duda, que tienen que ser así, y eso es lo que hemos aprendido durante todo este tiempo, e ir evaluando esa implementación, si está ocurriendo correctamente. Y lo segundo que tú también dijiste, Carolina, es cómo reacciona la comunidad frente a esos programas. Que eso también es muy importante, llevar el termostato, llevar cómo va la comunidad viviendo esos programas, porque eso es lo que nos va a hacer cambiar realidades probablemente. Yo lo plantearía así para el debate, para ver opiniones en América, en Europa, en Asia, en África, si esto les hace sentido o lo debatimos un poquito más. Gracias, Carolina, gracias, Inga.
Thanks, Mariano. As always, so clear, and I think that your plan is perfect. At least what we need to do is the measurement or intervention or measurement of the intervention can be the same for everyone, but the work that is between the evaluations needs to be localized and owned by the people of that community. So I think we agree fully, as so often before. I see a hand. Camila.
Hola, sí, muchas gracias.
¿Cuál es, cuál es, cuál es la organización que tienen las comunidades? ¿Cómo reciben las comunidades la oferta programática que estamos entregando? ¿Y cuál es, voy a decirlo como a veces lo plantea Mariano, ¿no? ¿Cuál es el cimiento que tenemos para ir construyendo prevención con las comunidades? A veces, en nuestro afán técnico de expertos, y lo voy a decir entre comillas, creemos que las comunidades necesitan un programa que puede ser que sea de prevención selectiva o indicada, pero las comunidades todavía no están preparadas para recibir un programa de prevención selectiva indicada. Y tenemos que construir un cimiento fuerte que más bien tiene que ver con prevención ambiental, que tiene que ver con sensibilización de esa comunidad, que tiene que ver con hacer un programa de prevención universal que luego nos sostenga las intervenciones de prevención selectiva e indicada, que son intervenciones más intensas, que a lo mejor requieren haber trabajado temas de estigma con esas comunidades para que podamos proyectar el trabajo preventivo. Me parece que a eso se quería referir Camila con lo que estaba planteando. Sí. Espero haberte interpretado bien, Cami.
Sí.
Sí, claro, gracias.
Yeah, no, thanks, Cara. It was wonderful. Yeah, I think we're all in line. We're going down the same lane, and the key is that we're going to down the same lane together. So that's, I think, is very good. So, Maria, can I give
Thank you.
you the floor?
Thank you very much. Can you hear me okay? Wonderful. Thank you. Yes, I know sound is often a problem. So such interesting and useful comments from Mariano and from our colleagues at Sundan. I wonder if I can try and string these together, though, in a way that's logical, because I think Mariano was talking about two types of evaluation. One is your large, overarching prevalence, incidence, et cetera, at a large national and policy level. And then he brought it down to your local level. And that is where our local diagnostics will be absolutely essential. And these are often two different, sometimes very different approaches to how we measure prevalence and incidence. I'm very glad that Mariano raised incidence. Incidence is the measure of new users, and it's often forgotten in our studies, both in our diagnostic studies and our national studies. And it's important because the prevalence tells us how many people are using in a given point of time. But it's the incidence, the number of the new users, that really tell us if the prevention itself is working. Treatment has a bigger impact on prevalence than prevention does, at least in the short term. And so having both of those measures in there is absolutely essential. But I think where Mariano was bringing and where Carolina was picking up is that there are two different pieces that we need to make sure are both included. One is our large overarching policy evaluation, which comes from our big studies, those large trend studies, those population studies over time. And then the other one is what we're doing at the local and community level. That is closer to evaluating the programs and prevention interventions themselves. So one is the larger policy we measure, the other is the local programs. And although some of our large studies can give us information on the local, we need to do those local diagnostics and make sure that they are addressing the specific needs of that community. And that's where I think Carolina was coming in. And that is, in order to do a good local community level intervention, we must do a diagnostic of those specific needs so we know that we are responding to them. And one of the issues I see, I think often, a conceptual mistake we make in prevention science is that we tend to want to find the program that worked somewhere else and apply it, where what we really need to be doing is finding the diagnostic studies that really communicated to us what's happening at a community and replicate those so we can build the program that responds to that community. I think that Carolina was getting at that. It's really understanding the community level. And these are different types of measures in prevention science and treatment science that we want to make sure that we don't lose. So I just wanted to pull that together because our colleagues from Chile, I think they see this very clearly. They've done a lot of work here. But there's a series of different steps and different types of measures, all of which are important, but have slightly different objectives along the way. And it's keeping all of those present as we move forward, especially right now with this issue of synthetics, because it really changes the way we have to measure use, because a lot of people don't know what they're using. So at any rate, I would like to thank Mariano and our colleagues from Senda, because I think they raised a series of really good points, and those points are interconnected, but each one has its own objective. Thank you.
Thanks, Mary. This was very good input. So for me, maybe I've been too long in this kind of work that measuring the success or not of each program is very much what I've been doing practically for the last 25 years. But what I've learned is also that if you just simply, you can always measure before, after, throughout the work, but the work needs to be developed by the people who are using it. We cannot tell anyone this has worked here, this will work with you. So it needs to be like tailor-made, although the studies on whether this works or not, they can actually be the same. So we could talk about this for 2 hours, but let's meet again over coffee somewhere. Okay, so who's up next? Ahmad, you've been waiting. The floor is yours.
Yeah, thank you. Thank you very much. Can you hear me clearly? Okay, thank you so much. Thank you, all, the global experts. But, to my, working with the sectors, after INL's Colombo plan and some other international organization implementation, the sustainability to some countries, the sustainability of these initiatives is a big challenge. In some countries, some countries they are working. In some countries, the government didn't realize it's taken a serious issues. Malabar drug abuse is serious, and to some countries, if you work with the community, with the support, if the donors is there, then the organization working. If there are no donor, government didn't realize it. To some countries, it's a issues we can work in this sector without the supports of all the stakeholder, the respective countries, especially in developed countries, you know, these programs not sustained. But regarding the prevention, it works. You know, the youth is working. The trends so many programs, but in treatment, it's still there are no, in some countries there are no government supported treatment initiatives. There are some private, you know, that the treatment is very, you know,
His connection is lost, apparently.
Let's give him a few seconds to come back to us. Because I think he was coming up with a very important thing. One of the things that we always need to keep in mind is that prevention is long term. It's into the future. So all projects that are kind of based on work for 2 years and have money to create that two-year program, it doesn't work that way. We have to get the ones in charge of each community to take part. And actually, what has changed since I began in this work is that politicians, they really want to take part in this because this is something good. This is, you know, clears their conscience a little bit. So it's much easier now to get them on board than it was 25 years ago. I am afraid we lost him. We'll just bring him in again if he shows up. Mariano, your hand is raised.
No, he's here. He's here, Hamad. Hamad, finish.
Yes, actually, I'm sorry because due to governments, you know, there are some strike. That is why they banned internet. Still, we are facing the issues. So that is my main, you know, although, you know, with the supports of the organization, especially, and now it's working. When I was joined, you know, the first, when I was participated in the 6th Asia Youth Congress, Bali, Indonesia in 2008. From where my motivation to work in the field of sustainable use prevention. At that time, there was no any, you know, trend people, even we don't know the sustainable use prevention issues. Now there were thousands of trends professionals here. Yes, as you know, some of the politicians, they, you know, realize this is the big issues. If human resources developed countries is developed, to some extent, it's about the sustainability of these initiatives. If we can support from the, you know, respective countries, you know, for funding support from these initiatives for long terms, it, you know, gives more impacts in the future. Thank you. Thank you so much.
And thanks to you, really very important. So, Mariana, do you want to take there is 2 hands up, but the floor is yours.
Solo, gracias, Ingadora. Solo reforzar lo que dice Ahmad. Afortunadamente, este foro de la Coalición Global es un foro gubernamental. No es un foro no gubernamental, es gubernamental. Y eso creo que es crucial porque no es posible finalmente lograr cambiar realidades macro, grandes, si los estados no están comprometidos con las políticas públicas para mejorar la realidad de sus pueblos. Las organizaciones no gubernamentales pueden ayudar muchísimo, pero jamás van a cambiar las realidades totales de un país. Entonces, este llamado de Ahmad de que haya seriedad en el compromiso de los gobiernos, eso es crucial. Nosotros, ¿qué es lo que hemos hecho aquí como organizaciones internacionales y como profesionales, muchos de ustedes? Damos la evidencia científica y decir la prevención sí sirve, sí hay ciencia, sí es efectiva, sí podemos hacer las cosas bien. Por lo tanto, es ahora lo que dice Ahmad es que tiene que tener decisiones políticas y además financiadas. para que tengan sostenibilidad. Ese es un concepto. El otro concepto importante es que lo que estamos conversando es que la evidencia científica es muy importante y tiene que someterse sin perder evidencia a un proceso de adopción en un lugar para que haya, primero, adaptación en un lugar sin perder la evidencia y después adopción de aquel programa. Porque si no hay adaptación y no va a haber adopción finalmente. Y para que eso ocurra, finalmente hacemos una implementación. ¿Ah? Y eso es lo que podemos evaluar después si es efectivo o no. El otro concepto importante que discutió, que planteó Camila, que yo creo que a lo mejor también hay que ponerlo con más relevancia, es algo que hacen varios países. Yo conocía que lo estaba haciendo Suecia, Ingadora, tú lo debes saber, Fakar lo estaba haciendo, que es la capacidad preventiva del territorio. Es decir, una cosa es evaluar las necesidades de lo que pasa en un territorio y otro es evaluar las capacidades preventivas que ya existen en ese territorio. Y frente a eso se generan programas y sistemas que puedan adoptarse e implementarse. Yo creo que ese concepto es un concepto que tenemos que tenerlo bien claro para que podamos progresar fuertemente y siempre evaluando incidencia, prevalencia e iniciación del consumo de los que consumen. Eso quería conversar. Gracias.
Thanks, Mariano. Very, very important to keep in mind. So, Jimena?
Sí, gracias Inga. Bueno, buenos días o buenas tardes, según donde estén, o buenas noches. Sí, yo creo que uno de los problemas con los que nos encontramos en prevención es que todo el mundo cree saber lo que es bueno para prevenir. Y justamente coincido con lo que dice Amad. De alguna manera, los políticos cuando llegan a sus cargos a veces llegan con unos eslogan o con unas buenas ideas de qué es lo que vamos a hacer para prevenir. Y no les gusta mucho esto que sea un trabajo que tiene resultados en el mediano plazo. La prevención nunca tiene resultados inmediatos, sino que tiene que ver con un esfuerzo sostenido y dar resultados en el medio plazo. Entonces, generalmente los políticos les quieren y necesitan mostrar, ¿no? Cortar cintas, inaugurar, mostrar, sacar eslogans. Entonces, creo que uno de los desafíos que tenemos es cómo podemos satisfacer la necesidad que tiene el político de mostrar resultados, pero al mismo tiempo de mantener el trabajo serio, basado en evidencia. Y justamente creo que antes de comenzar a trabajar en prevención en un territorio, junto con lo que dice Camila, que es importante ver cuáles son los recursos que ya hay en el territorio, es muy importante haber tenido la conversación sobre la sostenibilidad posterior antes de empezar. Porque si no pasa eso, que a veces los países, ante la oferta de los organismos internacionales, por supuesto que aceptan, pero luego no hay sostenibilidad. Entonces creo que es una de las conversaciones que hay que tener al principio, no cuando ya estamos terminando de implementar o terminando una capacitación y ahí ver cómo le vamos a dar sostenibilidad, sino que creo que es de las conversaciones que tiene que estar al inicio. Y también asimismo el desafío para nosotros los técnicos es ver cómo podemos satisfacer en alguna medida la necesidad que tiene las autoridades políticas también de mostrar resultados. Y en ese sentido las evaluaciones intermedias creo que son una muy buena herramienta para ir mostrando avances del proyecto o del programa o del proceso. Eso, muchas gracias.
Thank you, Mary. This is, you all speak of such good sense. So it's very important to measure. In my mind, we're always measuring the community. And if we see that a community is doing well, it needs only take it, and it's tremendously interesting how short time we can see positive results, even for politicians who only have 4 years ahead. We can tell them, we have some things that might be beneficial for your next generation. Actually, now it's kind of doesn't look good if they say no, it doesn't look good for them, which is really good. So they are easier to come on board than they were a while ago. So, Gloria.
Hola, buenos días, buenas tardes. Sí, apoyando y ampliando un poquito lo que ya nos decía Jimena, nosotros como técnicos en el área de prevención, es importante que sepamos con lo que contamos y cómo vamos a sostener eso, cómo vamos a seguir gestionando y la sostenibilidad también. Y tratar de hacer el lobby en todos los campos, o sea, darle los insumos a nuestros comisionados de drogas para que puedan hacer este lobby político sin nosotros despegar los pies de la tierra y pasarnos siempre todo lo que hagamos en evidencia, porque nuestros recursos son mínimos. Entonces tenemos que maximizar recursos y saber aprovecharlos para no desperdiciar y que sepan que con poco hacemos mucho. También es importante hacerles comprender de que en esta área no pintamos jarrones ni somos maquilas de ropa, entonces mucho es bastante, o sea, poco es mucho, en el sentido de ir sembrando una cultura de prevención, o sea, de ir haciendo de forma escalonada, un paso a la vez con lo que tenemos nosotros como El Salvador. Somos un país muy pequeño en territorio, llena de mucha voluntad y de muchas ganas de hacer las cosas bien. Entonces, pero priorizamos un territorio, ya atendimos este territorio, dejamos capacidad instalada, vamos con el siguiente y así vamos también tratando de ampliar con nuestros programas y también en las diferentes edades. Entonces sí, es muy importante saber y mantener que prevención es planificación, que prevención es ciencia, prevención no es improvisación y mucho menos es algo antojadizo. Yo le decía bromeando un día a mis compañeros que debería de ser delito calificado el que cualquier persona llegue a cualquier parte y dar una charla y decir que con eso previene, porque no sabemos qué tanto mal hacemos con creer que estamos haciendo las cosas bien y no es así. O sea, prevención es una ciencia basada en evidencia y tenemos que estar apegados a eso. Así es que solamente gracias.
Thanks, Gloria. Really very important point. So, I see that we have over 80 participants. Are there more people that would like to share something? And did I lose my co-chair? Or was I too upfront in taking charts? Where is Caro? She must have had to leave. No, but I feel that this group, at least, I haven't gotten a negative response. I think we can be proud of where we are today. Just having started to work together on a global, to solve a global matter, the same matter that is threatening the lives of children and adolescents in each and every country. So yeah. Anyone else? The good thing about this meeting was that it was supposed to be give people an opportunity to speak up, and and let
Sí,
people
buen
know,
día,
let us know
buen
what
día,
is the most present. Jorge, yeah, sí,
buen día.
buen día.
Bueno, escuchando todo ¿me escuchan? ¿Me escuchan? ¿Me escuchan? Buenos días.
Sí, te vimos.
Bueno,
We can hear you.
yo voy a comentar rápidamente. eh, yo trabajo con un programa de la gobernación del Meta. Es un departamento aquí de Colombia. Y trato de entender las dinámicas universales, todo el sistema político, la geopolítica internacional para el abordaje de las problemáticas que se están generando a través de las distintas sustancias psicoactivas que afectan o ponen en riesgo la humanidad, porque eh, hoy en día se ve esta amenaza muy cerca, demasiado cerca de las poblaciones jóvenes. Y hablamos de prevención universal, indicada, selectiva, etcétera. Hablamos de los procesos comunitarios, de las capacidades institucionales, de todas las experiencias exitosas que se tienen a nivel global. Pero también hay que entender cómo los grupos de narcotraficantes están entendiendo las dinámicas que se están llevando a cabo. Esas políticas internacionales ellos también las conocen. Y uno ve acá, por ejemplo, en lo que yo trabajo prácticamente en las zonas de microtráfico, trabajo de esos sectores donde las políticas públicas escasamente llegan, ¿sí? A pesar de todos los esfuerzos que se están haciendo a nivel territorial. Se están llevando a cabo una cantidad de procesos de intervención, pero veo muy distante las intervenciones en las zonas que están mayormente impactadas por el narcotráfico y el microtráfico, por el consumo. Son escasas, son excluidas de las políticas públicas. Entonces, ahora entiendo que las comunidades deben generar sus propias capacidades, fortalecimiento de capacidades comunitarias, pero debe generarse en esas políticas de orden gubernamental que respondan a esas necesidades, porque cada vez el narcotraficante sabe de lo que se está hablando, de lo que se está diciendo en los programas de prevención. Ellos conocen todo, saben qué se está hablando y a dónde se va a intervenir y de qué manera se va a intervenir. Entonces, es importante que dentro de esos procesos de seguimiento, de evaluación, se tenga en cuenta cómo están operando las bandas criminales, porque esto es rentable, porque ya están diciendo, vea, ustedes están en la pobreza, ustedes, el Estado los tiene abandonados y yo les ofrezco esas alternativas. Veo cómo las familias están empezando a ser instrumentalizadas en la venta de sustancias, en el microtráfico, en las economías ilícitas. Estamos hablando de la prevención, pero también tenemos que pensar en cómo la instrumentalización se vuelve también un riesgo, porque es la necesidad directa de no tener que comer. Y estas comunidades se están viendo involucradas en ingresar a estas actividades ilícitas, los jóvenes, niños que se usan para este tipo de actividades, y esto se va llevando de generación en generación. Entonces, pensaría que hay que tener demasiado cuidado también. Si se plantean estas políticas públicas, deben ser muy analizadas y correlacionadas con las dinámicas sociales y particulares de cada uno de los contextos sociales de los territorios. Me parece muy bueno e interesante lo que decía la compañera chilena, que hay que ser un poco más directos en el ejercicio y disponer una política pública mayormente, o sea, más directa a los sectores. Y veo eso. Y entonces buscar alternativas, ofertas institucionales que estén más de cerca a estos territorios y que acompañen las comunidades a decidir. Es lo que estamos tratando lo que observo del trabajo que se viene realizando acá en el territorio. Son infinidad de sitios de microtráfico camuflados, cantidad de familias reclutadas para el microtráfico, para el narcotráfico, cantidad de jóvenes que pierden su libertad por estar en actividades ilícitas. Entonces hay que revisar.
Thank you, Jorge. I think the conclusion of this meeting is that the task is not easy. We will have to do this together, and we will have to do this on every level. We know that we are dealing with really strong a group of greed, a group that is only in this for the money and don't give a damn about our children and adolescents. So that said, I think we are running out of time, and there was this one comment that came up mentioning that it's very important for us to include youth and young people in our work. My mind, of course, is always on primary prevention, and I'm constantly talking to adolescents, and this that's really very important. They are very, very smart, most of them. So I think we are done. It's 2:00. Everything you're all okay with the meeting?
Absolutely. Thank you so much, Ingadora and Carolina, who I think had to drop. But yes, thank you so much for leading such a wonderful and engaging and discussion-oriented session. This was wonderful. Thank you so much. Like you said, yes, we will have to transition to the next session. So Connie, if I could ask you to stop the recording and then provide. Right, there we go. And Anne, if you wouldn't mind sharing the slides for me, thank you. Wonderful. Hello, everyone. My name's Sarah Finmore. I am pleased to provide us with the administrative announcements today. Brian is on well-deserved leave. Welcome to this August session of Subworking Group 3.2. This will actually be our final subworking group meeting, as next month, September, we will regroup in our 3 larger working groups to discuss the first year and check in and plan for the future. So to begin, I wanted to start, we wanted to start by thanking our co-chairs, Dr. Nicholas Priest and Yuri Kutipe, for all of their work over the past 11 months. It's been a very intensive program, and we are so grateful for your dedication and your effort and your time. I also want to thank our international organization coordinators for 3.2, Ms. Anya Boost from UNODC and Jose Luis Vasquez from CCAD. Y'all have been excellent collaborators over all these months, and we're very grateful for all your support in identifying speakers, organizing these calls, and just moving forward the coalition's work overall. Without our co-chairs and our international organization coordinators, we wouldn't be able to do it without you. So turning now, the theme for today's meeting revolves around monitoring, evaluation, and transitioning for stability. Because now that we're coming to a close of the first year of the coalition, and we have such a diverse membership, and we need to look at how we move into this next phase so that it's more manageable and easier to organize. We come from so many different backgrounds, so many different professions, that to really make progress in this next chapter, we need to find a way that we can manage the work in a targeted and more manageable fashion. Specifically because our success moving forward is going to be measured by the outcomes of the actions and the initiatives that we take on, which I'll come back to in just a moment. We can go to the next slide, please. So now that we're thinking forward, let's also take a second to acknowledge the accomplishments and what's happened so far. Think back to last July when we had the virtual ministerial that launched the coalition, and think about how it was such a demonstration of the high-level political commitment to address synthetic drugs, with top leadership from over 80 countries answering the call to action. It instilled this sense of urgency and a focus that has led to these productive meetings and action lines that we've held over the last 11 months. And so this slide is going to outline some of these accomplishments. So first, right off the bat, we've developed a network of over 1,600 government representatives from 158 countries and 15 international organizations, which is a huge number of folk united with a common purpose to find these practical solutions to address synthetic drug threats. Also, in total, by the end of the September sessions, we will have engaged in 148 hours of virtual meetings with interpretation in 7 different languages. So many people, no matter what language you speak, we've been able to discuss and try and understand the problem, exchange experiences, share opportunities, and discuss new ideas. Also in May, think back, we worked together to identify 68 recommended areas of work across all of these sub-working groups. And also international organizations compiled roughly 120 initiatives to act on these recommendations. Finally, we had in-person meetings, one with our working group 2 co-chairs in Italy, and also in Greece, where all of our co-chairs, or as many, we had about 40, I think, co-chairs from all of our working groups come together. And through these meetings, there was a realization that this issue is going to require continued and intensified cooperation, as well as funding and resources for many years to come, because we know that this is not an acute issue that is solved. It's a chronic issue that continues to worsen and requires the continued attention of the international community and developing new and strengthened responses and ways of and strategies of addressing the drug phenomenon. So in sum, a different way to think about it is this past year, we've been focusing on building the car, building the infrastructure, but now comes the time to start driving it. The many hours of meetings that we've had have shown the scope, the intensity of our work, and the extensive nature of the synthetic drug phenomenon, which requires that intensity. So we really want to once again sincerely thank you all on the call, all who have joined the calls over the last 11 months for your dedication, your participation, and the endurance for what we know was a lot of time given everyone's busy schedules. But like I said, it's been a meaningful exercise, and so we very much appreciate your collaboration. So moving from there, let's think about what else we've accomplished. We've established new networks on the health side, the launch of the Global Recovery Network, the Global Women's Network, and the International Consortium for Alternatives to Incarceration, or ICADI, will move people from the criminal justice system into community-based treatment services. And also, we have a new network that we've mentioned and we've discussed before that will be coming in the future, the International Network for Legislation on Drugs, or INLAD, which will help fill some of the legislative and policy gaps that have been identified. And overall, we've been raising the profile of the many methods. We can click to the next point, and thank you, yeah. Overall, we've been raising the profile of the many methods out there for addressing synthetic drug threats. Like I mentioned, that over 120 initiatives from international organizations span from intelligence and information sharing platforms, disrupting manufacturing and trafficking of precursors, training programs, capacity building opportunities, and more. And we've already seen coalition participants expressing interest in these programs, which shows an excellent signal of engagement and progress forward. I also would like to raise the issue of donors and developing funding support packages for the coming year. And here I'll mention INL. We are specifically looking at about 30 initiatives that we want to support from the menu of initiatives and have really oriented our programming to support the global coalition almost exclusively for this coming year. So now what is left? As I mentioned, we built the car and now we need to get moving. We need to operationalize all that we've been discussing. And there are 3 lines of effort we would like to propose going forward in the coalition after September. In the first line are collective coalition meetings. One that we are looking at is holding a donors conference to coordinate assistance that is already being provided and take stock of additional needs that the international community is facing, so that we are aware of what is being contributed and what also needs to be contributed. Second, we are considering a thought leaders conference as an activity for the next year. The idea being to convene academia, think tanks, and also policymakers to bring research, legislation, practice together and help look at a forecast of where the field is going, where synthetic drugs may pose a greater risk in the future, and then what patterns are looking like so we can try to undermine and address some of those challenges proactively. So while these monthly meetings may wind down, the coalition will continue to meet and convene and touch base at various times, and we look forward to your feedback in terms of recommendations for doing so. Second, we are considering regional meetings that are organized by our various international organization partners and regional organizations in order to help or to continue understanding these dynamics. One, we're looking forward to a Middle East drug dialogue taking place on October 15th and 16th in Hungary, where the African Union will be assembling supply reduction focal points in Madagascar and demand reduction experts in Tanzania later this year. Looking forward to Pacific Island meetings in a similar format, focused on one demand and one supply. Additionally, the Organization of American States is helping to arrange meetings for the Western Hemisphere, and UNODC, as in past years, is supporting the convening of Central Asian drug authorities. And there will be plenty of other meetings, I'm sure, through North American governments and European governments, which is something to look forward to. So the world is coming together, as we've seen through these regional forums. Third, in terms of lines of action of how we carry forward the momentum and in pragmatic terms, well, so by September, we are hoping to have reports from sub-working groups and working groups on specific and concrete initiatives and actions that they would like to implement and to commit to, so that we can then form smaller groups of interested countries and interested individuals to then carry forward in kind of smaller groups rather than the overarching thematic groups we have now. So if your country or if you as an individual within your government are interested in participating in some of these, over the next month, there'll be the opportunity to identify those and then join to move forward. We can go to the next slide, please, Anne, thanks. The website will remain the organizing platform for the work that we're doing, and there we are putting together a calendar that shows the different opportunities to plug in to connect in these different lines of action that I mentioned before. But in terms of what carrying forward the lines of action means, we have a couple examples that can illustrate what this looks like. So first, for example, is the legislative network I mentioned earlier, INLAD. So what a year might look like for a participating parliamentarian or their staffer. In October, UNODC plans to conduct an initial launch with the Organization of American States, CCAD, subsequently launching a pilot for the Western Hemisphere. So if your government or an individual within your government is interested, you might express that interest to participate in October. And again, these examples are hypothetical and plans are still in process, but in December, there could be an in-person meeting that identifies priorities for the legislative development. For example, class-wide scheduling that legislators might want to take up and share sample legislation on. So from January to June, staffers of their respective countries could finalize and work with legislators to either introduce a bill, legislation that could be adapted, and then by July or August, outcomes could say the number of draft laws or bills that were considered for approval, the number that passed, that shows how the drug control architecture is stronger because of these efforts. A second example could be around just general development of training programs, identifying participants, collecting baseline data of and what is the definition of success or impact, and then later on, conducting a training that includes mentoring and technical assistance, and then later having an assessment of impact. So these are basic but illustrative examples, and now I have talked enough, so I'm going to turn it over to our co-chair. I saw Dr. Nicholas Priest on the line, and I'm not sure if Yori has joined yet, but Dr. Priest, over to you, and thank you all for listening.
Bonjour Sarah, bonjour à tous. Merci beaucoup pour cette présentation résumant ce que nous avons fait, nous donnant des perspectives et des exemples qui illustrent très bien les choses. Je prends la parole donc en découvrant le programme que vous nous avez envoyé qui va s'orienter autour d'un certain nombre de présentations, 3 très exactement aujourd'hui. Et notamment, je vais passer la parole à Colline Christophis du département Health and Aged Care sur les programmes de Take Home Naloxone pour nous faire part de son expérience et qui certainement générera un certain nombre de questions sur l'efficacité et la manière là aussi de pérenniser ce type d'action. Colline, vous êtes avec nous? Je n'entends pas Colline.
I apologize. He's joining via a video, which I will share now. One moment.
Ok, magnifique. Magnifique.
So good afternoon or good morning, wherever you are in the world. So my name's Colleen Christophis and I work for the Australian Government Department of Health and Aged Care. I've been in this role for several years. However, my background is working as a registered pharmacist. There are multiple programs that my area manage, and these programs relate to affordable access to medicines. So one of the programs our area look after is the Take Home Naloxone or THN program. So before I begin, I'd like to acknowledge the traditional owners and custodians of the lands which I'm meeting today. I'm on Kaurna land and I pay my respects to elders past, present, and also to any Aboriginal and Torres Strait Islander peoples who may be joining the call today. So firstly, I'd like to thank you all for the opportunity to present to you all today. There's some great work that goes on in this forum, and it's a great opportunity for me to share our experiences for implementation of the Australian THN program. It's a great program which benefits vulnerable Australians. So some of the topics I'll be touching on are listed on the slide. So the statistics on the screen are from the Australian Institute of Health and Welfare and the World Health Organization, and also the National Drug and Alcohol Research Centre here in Australia. I won't read through all of the statistics shown on the slide. However, you can see that opioid overdose is a burden to health and mortality in Australia, with the rates of opioid-related deaths and hospitalisations increasing. There is increasing concern for synthetic opioids which are entering the market, particularly nitazines, which are unknowingly mixed with other substances in Australia. So I anticipate most of the people in this forum would be aware of naloxone and how it is used to temporarily reverse effects of an opioid overdose or adverse reaction. I believe it's important for me to remind everyone that an ambulance will still need to be called after administering naloxone, as a person can still overdose. So prior to establishment of the THN program in Australia, naloxone could only be purchased privately from a pharmacy or subsidised with a prescription through our Universal Medicines Access program called the Pharmaceutical Benefit Scheme. Since 1 July 2022, naloxone is also available through the THN program. The THN program is funded by the National Australian Government, while our individual states and territories are required to provide a small amount of funding for distribution through some providers. The THN program makes naloxone available at no cost and without a prescription through a special program. Individuals who may experience or witness an opioid overdose or adverse reaction to opioids are able to request naloxone. And through feedback through the consultation process, the program was designed so that no identifying information such as social security numbers are collected when providing naloxone under the THN program. So initially, prior to the national rollout of the THN program, we had a pilot program run in 3 Australian states from 1 December 2019 to 30th of June 2022. One of our universities, the University of Queensland, was engaged to conduct an evaluation of the pilot program. And the findings of the evaluation were used to inform a government decision to create the ongoing program across all of Australia. A copy of the final report is available for viewing on our website, and I'll be happy to provide a link to this. So the report used a mix of data collection activities, and some of the findings showed consumer uptake was increased by removing the costs and access barriers, and availability was increased through a broader range of access sites. The key findings from the evaluation demonstrated the success of the removal of these barriers, and some of these are shown in the graphic on the bottom left. So naloxone was used 1,649 times to reverse an overdose. It saved 3 lives per day, which includes improvement in both prognosis and reductions in mortality. And we had over 43,000 units of naloxone distributed to individuals. So some of the suppliers include community and hospital pharmacies. We do have some dispensing medical practitioners or doctors who are approved to supply pharmaceutical benefits in Australia. And then what's unique to this program is distributing naloxone through non-pharmacy suppliers, which are known to our program as authorised alternative suppliers. So some examples of these include alcohol and other drug treatment services, needle and syringe program sites, and custodial release services. So in Australia, usually the advice of the pharmacist is required to permit the supply of naloxone. There's been changes in legislation to enable supply of naloxone by other providers. And some of these arrangements have also helped to remove the barriers to access naloxone. Approximately 90% of the naloxone supplied through the program is still through pharmacies, but it's still important to have all these other access points. We had feedback from our stakeholders that stated that some people feel stigmatised when asking for naloxone through a pharmacy, and having these other access points enable people to feel safe when requesting naloxone. There are 3 formulations of naloxone available in Australia. So these are the nasal spray, pre-filled syringes, and ampules for injection. And the nasal spray is the most popular form, which accounts for about 80% of our expenditure on the program. One of the requirements for suppliers to provide naloxone through the THN program is to provide some simple data with each supply. So we have an online portal which is used to submit and collect program data, and claims are also paid through this portal. The data collected is listed on this slide, and you'll notice, as I previously mentioned, there's no identifying information collected for this program, and this is to increase accessibility. Where they may not feel comfortable to provide information when requesting naloxone. Although a reason for refill is not mandatory, the patient doesn't have to consent to this, but this does provide some useful data for us to look at. And some of these statistics on the next slide. So there's been over 346,000 units of naloxone supplied to Australians from the 1st of July. 2022, and most of the suppliers where consent was approved to collect data were initial suppliers. 15% of these were supplied as a refill. And we can see that naloxone was used over 10,000 times in Australia over a 2-year period. We developed some education materials, and also some training modules. So some of them were directed at healthcare workers and some at pharmacists. So the education was to provide a refresher on naloxone, about the program itself, and suggestions to help initiate a conversation with individuals on the importance of naloxone. On the slide, we've got some of the flyers and promotional materials that we produced, and these were directed at people for low health literacy as well, with these easy to use follow diagrams. And we also had some other promotional materials which I've got on the slide. Although the program delivery has been successful, there have been some challenges along the way. So one significant hurdle in the implementation was overcoming the different legislation within Australia, as we have different states and territories. So we did have to work with the different jurisdictions to make sure we could deliver the program equitably across all of the jurisdictions. We also needed to continue engagement from the state and territory health departments to make sure that we could distribute it equitably. There's been rapid expansion of the program since we went live. To receive funding for the program, we needed to make sure we could secure additional funding as we've had more uptake than initially anticipated. And we're continuing to conduct compliance for the program to make sure that the product is being given to those who actually need it, and those who are actually at risk of an opioid overdose. We've also had some challenges with availability of naloxone in Australia. We had quite a few shortages, particularly during COVID-19. So we are on an island quite far away, so it can be difficult to obtain some stock. But we have a process through our medicines regulator to temporarily approve imported products to fill the gaps in the market. The nasal spray being the most popular, we did have one form temporarily approved from an alternative manufacturer, and so we temporarily listed this on our program to help fill some of the gaps. That's it from me. I've got the link to the report I referred to earlier from the pilot, but if there's any questions, more than welcome to send through any to the email address. That's all from me.
On va remercier Colline qui, à distance, nous a donc envoyé cette vidéo très intéressante sur l'expérience australienne. On sait tous que, d'après la littérature scientifique, la disponibilité de la naloxone est un des éléments très importants pour lutter contre la mortalité liée à la consommation d'opioïdes. Ce n'est pas toutes les drogues de synthèse, mais une grande partie de la mortalité repose aujourd'hui sur les opioïdes. On essaiera peut-être de lui poser des questions à distance. Moi, j'ai une réflexion qui est liée au coût qui a été mentionné par Colline, à savoir des coûts qui sont dans la réalité plus élevés que le programme avait été dimensionné, des questions d'approvisionnement. Et je crois que c'est important pour nous tous d'avoir une idée pour convaincre les politiques, les décideurs publics du coût de tels programmes, du coup par année, parce qu'il faut renouveler les stocks, il faut en avoir aussi certainement en réserve en cas d'émergence de cas très, très concentrés. Donc ça, c'est une question que nous, en tout cas en France, on se pose. On a un programme qui est globalement similaire, mais qui pose des questions de coût, et peut-être que la communauté de la Global Coalition aurait intérêt à regarder aussi l'intérêt d'une mutualisation des coûts pour les pays qui auraient des difficultés à subvenir à ce type de besoins, comme ça a été fait sur un certain nombre de médicaments essentiels dans le monde depuis quelques décennies. Voilà, mais je ne sais pas s'il y a d'autres réactions avant que l'on passe à la prochaine présentation. Je n'en vois pas. N'hésitez pas si vous avez envie de faire part de votre expérience. Bien, écoutez, on restera en contact avec Colline pour poser quelques questions supplémentaires, aller un peu plus loin dans ses expériences. Sarah, si vous en êtes d'accord, on passe à la prochaine intervention. Et c'est Anya Busse qu'on a vu à plusieurs reprises dans ce meeting de l'UNODC, qui va nous présenter ou qui présente par le...
Oh, ya sé. Usted va a entrar.
Anya, vous êtes présente? Vous êtes là? Non, c'est une vidéo.
Thank you so much for the opportunity to present here. My name is Anya Busse from the United Nations Office on Drugs and Crime, and it's my pleasure and honor today to present to you today on our work in Latin America, and especially on quality assurance and how that is enabling drug dependence treatment in line with the international standards for the treatment of drug use disorders, or in short, UNODC's QLAD project. So I will just remind us very quickly about the international standards for the treatment of drug use disorders and some of the quality assurance tools that have been developed based on the standards, and then share with you what you're really interested in, I think, today, some information about the QLAD project, which is kindly supported by the government of Spain. So the international standards for the treatment of drug use disorders, on which we count since 2020, have been developed, among others, to address a prevailing gap in the coverage of treatment of drug use disorders, and that's what you see here. UNODC estimates that only 1 in 11 people has access to any form of treatment of drug use disorders, and that still doesn't say anything about the quality of these services if and when somebody manages to get access. But the standards are really there to support member states in their efforts to develop and expand ethical, effective and evidence-based treatment for drug use disorders. They're based on WHO and UNODC technical tools and guidelines, and are guided by a number of fundamental principles. For example, that treatment needs to be available, accessible, attractive and appropriate, that it needs to follow ethical standards, that we need intersectorial collaboration, including among the health system, the social services and criminal justice services. The treatment needs to be based on scientific evidence and respond to the specific needs of individuals, as well as the special treatment and care needs of some population groups. It needs to be implemented with good clinical governance and in an integrated approach, looking also at the overall health and social services available. Treatment system, as described in the standards, follows a public health principle where we want to implement most of the most effective, least invasive and least costly intervention to reach the greatest number of people. And that very much leads us to strengthening outpatient and ambulatory services and integration into non-specialized health services. Treatment of drug use disorders in line with the standards can and should be implemented in a number of settings, from community outreach to non-specialized environments. Special outpatient treatment is the cornerstone of the treatment system pyramid, and we also need short-term inpatient treatment as well as specialized long-term or residential treatment. And there's surely no one-size-fits-all, but on a system level, as a policymaker, always good to keep the pyramid in mind. In all of these settings, a number of interventions can be implemented, in especially screening, brief interventions, and referral to treatment in non-specialized settings, evidence-based psychosocial interventions that we count on. Also, we count on evidence-based pharmacological interventions to treat especially opioid use disorders and address problems associated with overall drug use disorders. Then we need to pay attention to the treatment of co-occurring psychiatric and physical health conditions, and with a view to a longer-term continuum of care recovery management. The international standards for the treatment of drug use disorders in this format were launched in 2020, thanks to the support of the US State Department, and in 2023, we now could also launch the official translation into Spanish, the Normas Internacionales para el Tratamiento de Trastornos por Consumo de Drogas, thanks to the government of Spain. So based on the international standards for treatment and to support their implementation, a number of quality assurance tools for both drug use disorder treatment services and systems have been developed by UNODC, and especially the key quality standards for service appraisal have been developed by a cooperation of different agencies, including UNODC, the World Health Organization, the African Union, the Colombo Plan, the OAS CICAD, and the COPOLAT project. So all of these are living documents for technical assistance, and we are seeing adaptations and experiences emerging at different national and regional levels. Here you see an example how quality appraisal workshops function, usually following a color system. When a standard is met, there is a green check. When a standard is not met, there is a red check. But the workshops are a little bit more complex, but this is just to give you a bit of a taste. The key quality standards for service appraisal, which we share with our partner agencies, focus on especially effective management of services, the need for individualized, person-centered treatment and care, timely access to evidence-based interventions, and the promotion of health, safety, and human rights of the patients. We have, in a literature review, further looked at the relationship between quality of specialist treatment for substance use disorders and patient outcomes, and where there was a special evidence for was that timely access to person-centered treatment and opportunities for patients to receive ongoing care have been associated with positive benefits in patient outcomes. So that to keep in mind, as in the end, the well-being of patients or clients is the ultimate quality indicator. So in these kind of circles of continuous improvement, we are supporting UN member states in their efforts to appraise treatment services and systems and to institutionalize quality assurance cycles and mechanisms. We provide technical assistance for that and help to monitor quality improvement over time. And this has been done in this case by UNODC in a number of countries around the world. And this is a region we want to look at specifically today, Latin America and the Caribbean. And I'm happy to present you this project on quality assurance and drug use disorder treatment services and systems in Latin America, QLAT, as said, kindly supported by the government of Spain. We are currently working with Bolivia, Ecuador, Colombia, El Salvador, Guatemala, Honduras, Mexico, Panama, Peru, and the Dominican Republic in a truly regional approach. QLAT was launched in 2020. The first phase went to 2021 with the aim of ensuring political support needed to significantly advance the process required in each country to implement the quality assurance framework for the treatment of drug use disorders. So some of the achievements of this first phase are that we developed a situational diagnostic tool to appraise a treatment system and a quality assurance system. And we applied this then in all 10 project countries, and reports are available. We also had national technical consultations with over 120 high-level representatives and professionals from project countries in this project. And each country developed a quality assurance roadmap with specific measures and priorities for the improvement of quality assurance mechanisms on drug use disorder treatment services and systems. Additional achievements of the first phase include the application or a pilot of the key quality standards in both Bolivia and the Dominican Republic. We did a training on quality assurance and thus increased the knowledge of over 150 professionals on the application of the key quality standards. 2 publications are available for everybody, a report on phase 1 that includes the major directions from the roadmaps. And we also did a mapping of the capacity of treatment services in the region. The reports are available to you. Here, just to take a closer look at the mapping of drug treatment services to give you a taste. Not all countries participated, but Bolivia, the Dominican Republic, Ecuador, Guatemala, Mexico, and Panama did. And overall, close to 400 treatment services from the region informed us about different features of the services that they are providing. So here is just an example. So the services, for example, indicated their affiliation. Are they more in the NGO sector, the light yellow kind of, which you see quite prominently here, or are they more in the public governmental sector, which you can also see, the darker green, but much less. And similar kind of mappings and graphics on other aspects you find throughout the report. Maybe to summarize a bit at the regional level, we found that while most of the services reported that people are seeking treatment for alcohol, cannabis, cocaine, and nicotine, also substances in the focus of the Global Synthetics Coalition were reported for in-being treatment, like other opioids, stimulants, including amphetamines, methamphetamine, ecstasy, benzodiazepines, LSD, ketamines, and others. We also found, which was interesting, that 44% of the participating facilities reported treatment for people who have used opium, fentanyl, and other opioids. This is interesting as overall the prevalence of opioids in Latin America is lower than in other regions, but from the treatment services that participated, many of them kind of also treated people with this profile. One of the challenges we identified is that few services indicated that they have specialized programs for women, only 20% said so, and even less, only 9% had special programs for pregnant women. And what's maybe also a concern is that there was a high number of services reporting that they rely on out-of-pocket payments of patients for service provision, so which could be really a barrier also for many people, especially those with low income. We are now in the second phase of the QLAD project, and we are continuing to support countries in what they have prioritized in their roadmaps, and we have a lot of regional activities and also go deeper at the country level. So for all project countries, a benefit is that the treatment standards have been translated into Spanish. We are also translating UNODC's TreatNet materials, including some online component on basic counseling, into Spanish. We're hosting regular webinars for the participant countries, and we're looking forward to our first in-person meeting in September in this project that so far has been implemented only online. There are two technical working groups, one which is focusing on treatment outcomes and how evaluation of such can be improved, and the other working group is for mutual support and the development of draft accreditation standards at country level for countries that did not have that so far. And then in some countries, additional work is going on. So for example, Peru and Bolivia will have a treatment training on treatment service implementation, and all countries are working on further deepening their roadmaps. So here you can see some of the products mentioned and how, for example, you can access the training materials that I have mentioned, including in Spanish too. The webinars that we are conducting for the QLAD countries are meeting a demand from all of those countries. So the focus is on intercultural perspectives, so especially how to provide better services for indigenous populations, as well as women and adolescents. And these groups or these webinars are really giving a safe space for the countries and leave enough time for discussion and exchange. And then I think I already spoke about the working groups A and B, where in working group A, we are supporting countries in the piloting of treatment outcome evaluation tools that have been used elsewhere, also in the region. And some other countries are very much making progress in the development of their own national accreditation standards. And then it said in Colombia, also especially at the country level, there is a focus on understanding better the needs for treatment for women. And also in Ecuador, activities are continuing at the subnational level, especially in Quito and in Ibarra at the northern frontier of Ecuador, where we have trained policymakers and supporting kind of digitalization of services at the Quito level. So here you can see we have only been virtual so far, but people really managed to build a network. QLAD come to meetings, and we are very honored and proud of this network and the mutual support and information exchange that is taking place, and happy to share with all of you the advancements and share also some of the deliverables, of course, of QLab that are now available to everybody. So in summary, I think we believe that the international standards for treatment of drug use disorders are not only a global reference point or cornerstone for what is quality in treatment, but with projects such as the QLab project, we can also demonstrate that they serve to implement quality assurance mechanisms at the systems and the service level, and that in line with the standards, we can in very concrete ways come to tangible deliverables that will improve services for people with drug use disorders, their families, and community. Muchas gracias. Thank you so much. If you would like to have more information, please write to me at anja.busse@un.org, and we would be happy to hear from you and share more from this wonderful project. Thank you so much for having us today. And with this, let me stop.
Une nouvelle magnifique présentation de la part de Anja et de l'EMDC sur ce sujet très important de la qualité de la prise en charge et de l'assurance qualité. Le temps passe, je vais vous demander de garder peut-être vos remarques, vos questions pour la fin de notre réunion. Et peut-être Sarah, si vous êtes prête, à moins que Betty et Laura ne soient en live avec nous, nous pouvons passer à la dernière présentation avant de garder donc un temps d'échange en fin de réunion.
I will share it now.
Parfait, merci beaucoup.
Actually, hold on one moment. I apologize about the technical issues, but I'm gonna fix it.
Non, mais qui est une présentation, juste pour l'introduire, qui a trait à une des difficultés dans la qualité des traitements soulignés par Anja, qui est la difficulté spécifique d'accès à des traitements de qualité par les femmes qui ont des difficultés avec les usages de drogue. Et là, l'expérience que l'on va écouter a trait justement à une analyse de ces facteurs à la Barbade, je crois. Sarah, si ça marche, c'est bon.
Not yet. I apologize. Just give me one moment. The file is loading.
Aucun problème. Si quelqu'un veut réagir à nouveau sur la présentation d'Anja ou voire même celle de Colline auparavant, ça peut être le moment aussi de vous exprimer en attendant ce dernier exposé. Ah, c'est parti. Je pense que c'est parti. Voilà.
Thank you.
Today, I will be sharing the highlights from a recent local study. Good day. My name is Laura Foster, and I'm a Research and Information Officer at the National Council on Substance Abuse in Barbados. Today, I will be sharing the highlights from a recent local study which investigated the barriers to treatment for women on islands.
Oui, personne n'entend, enfin, on a des difficultés à entendre la voix de Laura. Est-ce que on peut relancer cette vidéo? Oui, ça ne passe pas bien, Sarah, celle-ci.
I think the system is not allowing me to share the audio with you guys.
Yes, and the file is not operating on my side either. I think given the technical issues, maybe we will post it on the website since we have just 5 minutes left and maybe open it up for questions.
Ok, vous n'avez pas le son non plus en anglais, ça ne passe pas bien. Ok. Non, mais je crois que c'est la bonne solution, Sarah. On mettra cette vidéo sur le site et puis chacun pourra.
Sorry, let's see if this works now.
Good day. My name is Laura Foster, and I'm a Research and Information Officer at the National Council on Substance Abuse in Barbados. Today, I will be sharing the highlights from a recent local study which investigated the barriers to treatment for women on islands. This exploratory study sought to identify and describe the barriers from the perspective of both the treatment clients as well as the treatment providers. And it also sought to identify and describe possible solutions. For us, a treatment barrier was anything which prevented women from accessing treatment.
Oh, it appears Laura Foster is actually online. Laura, would you like to present in real time?
Sure, Sarah, I can. Give me 1 minute. Would I be able to share my screen? Do I have permission?
You sure do, absolutely. Thank you.
1 second. Oops.
Laura, vous nous entendez? Vous êtes OK pour faire la présentation en live?
Sure, I am just trying to get my presentation up. Give me 1 minute, because I wasn't prepared for it. So give me 1 second, and I should be able to share with you.
Thank you, Laura.
Merci beaucoup, en tout cas. Merci.
Give me 1 second. I think I had one error. I wanted to do my presenter view. 1 second. I'm back with you. All right. Can you see my slide?
Oui.
All right, perfect. All
On va y
right.
arriver.
So everything is good. Okay. So hello again, everyone. My name is Laura Foster. So I am a Research and Information Officer at the National Council on Substance Abuse in Barbados. And today I will be talking to you about a recent local study that we did, which looked at the barriers to substance abuse treatment, specifically for women in Barbados. So for this exploratory study, what we wanted to do is we wanted to identify and describe the barriers to treatment, but from the perspective of both the treatment clients as well as the treatment providers. And we also wanted to come up with some possible solutions. So we wanted to find out what these persons thought would be ways that we could use to reduce the impact of the barriers to treatment for the women in Barbados. And for us, we looked at barriers as both internal and external. So internal barriers would be things that came from within the individual. So their perceptions, their beliefs, fears, those sorts of things. Whereas external ones were things outside of their control. So we're talking about social factors, cultural factors, even something like the treatment program characteristics. Those too could be considered external barriers. And we also looked at not only what stopped women from coming into treatment, but what may, cause them not to come back after their initial assessment. So things that may not allow them to actually start the sessions, even though they had presented for help, as well as things that may have caused them to drop out of treatment prematurely. Now, because it was an exploratory study, we used a qualitative approach. So this meant that we did interviews with treatment providers. We also did a focus group with our treatment clients as well. And remember, as I said, we were looking at external and internal barriers. So what we found was that the external barriers were actually far more numerous. I think we found like maybe 7 external barriers and only 4 internal ones. So that's what this graphic here depicts. And for this one, I'm going to now start to talk about some of the barriers that we found. You can see here, I've selected 3 external ones and 2 internal ones. And again, some of these external and internal barriers for that matter, they may be related to women's unique roles and their responsibilities, but some of them are not gender specific. So there are things that can also affect men. In terms of childcare and child welfare concerns, what we found was that women typically are concerned about the safety of their children if they are going to be in treatment, particularly residential treatment. They want to know that they will be well cared for. And if they have these concerns and there's no one to assist them with childcare, no one they can depend on, then they may not seek treatment because they're too focused on caring for their children or their fears about their children. And this can often happen because women who are in treatment, many times they don't have good relationships with their family and friends because these have been destroyed by their active drug use. So they won't have that support network to provide the care and the safety they're looking for their children. In terms of stigma, we know that drug use is a highly stigmatized condition, particularly when we're talking about drug use among women. So in many cases, the women indicated that they don't present for treatment because they're fearful of being labeled and discriminated against by society. We also have an additional issue whereby our local psychiatric hospital is one of our local treatment providers for drug treatment, but it also is the main point of assessment for persons who want to have their treatment sponsored by the government of Barbados. And we know that much like drug use, mental health is also highly stigmatized. So what happens is that in many cases, women and often men don't present to the hospital for assessment because they don't want to be labeled as crazy by society because persons may think that they're really going there for mental health treatment. Absence of workplace drug policies is another issue. So in Barbados, workplace drug policies are only now starting to gain traction. So we find that a lot of the business houses don't yet have policies in place. So what happens is that persons become fearful that they may lose their jobs, they may be discriminated against by their co-workers, by their employers, if persons find out that they actually have an issue with drug use. Likewise, there's also the issue of access. So not having written protocols can delay treatment referrals. So if persons ask for help through their workplace, if they do not have protocols in place which outline, possible treatment options and how referrals can be made, that can actually delay the treatment access for the individual, even if they were brave enough to approach their workplace. In fact, one of the women in my study suggested that she had gone to her workplace for help, and they didn't have any protocols or policies in place, and it took them 8 months to figure out where to refer her and how to refer her. So that is just an example of the delays that can occur. Now, on the internal side, here we have denial, and we know that universally this is a big challenge when it comes to treatment. And it's not only for women, for men as well. The women spoke openly about how denial can actually prevent them from seeking treatment. So this aligns with what we're seeing internationally, right? But we also have the issue of a lack of knowledge about available treatment options. And what the women spoke about is the fact that there's often little known about what treatment options are out there in Barbados, be they outpatient, be they residential. And so therefore, even when a woman acknowledges that she has an issue, she wants to change, she can't get the help that she needs. So that will be something that will keep her out of treatment as well. Now, all that said, I'll give you some quick recommendations that came out of our study. So because of the great emphasis that was placed on childcare and child welfare concerns, we suggested the provision of childcare services for women in treatment. If women can feel comfortable and sure that their children will be well looked after while they're in treatment, they're more likely to come. They're also more likely to stay and complete the program. In terms of stigma, we know that things like stigma often come from misinformation or a lack of information about something. So if we think about that common misconception about, addiction being a choice rather than a chronic relapsing disorder, if we can combat the misinformation and raise persons' awareness, that may help to tackle stigma as well. So that said, we propose a public education campaign to specifically do that. Raise awareness about addiction, raise awareness about the treatment services that are out there. But we also know that language can be important. So just the way we speak about addiction can perpetuate stigma. So therefore, we also recommend following the international guidelines, which suggests that, we use language that reduces negative bias about addiction. Now, to tackle the big issue related to our psychiatric hospital being that point of assessment and a treatment provider, we suggest decentralizing the services that were offered. So we don't want them only housed within the psychiatric hospital. Let those psychiatric hospital services be, done in our community clinics, and make sure that those services are advertised, persons are aware of them. So people may not necessarily know what they're going into the clinic for, whether it be a mental illness, a physical illness, because the thing about our community psychiatric clinics is that they're actually housed within our community primary care settings. So where persons are going to access medical services and so on from doctors. So you can easily do that without anyone knowing what you're going for. In terms of workplace drug policies, we really need to push those here. So it's suggested that we have a national campaign that promotes them. Let's get everybody on board, show the business houses, the importance of them and the benefits and what they should include and those sorts of things. But that said, they will still need some guidance to develop their policies. So we would suggest that those resources be provided. And for us at the NCSA, we have already led quite a number of large organizations through the policy drafting process. So we are saying that, we've put our hands up and said, we can be that resource, right? So we're willing to do that and help policy organizations develop their policies as they go forward. In terms of denial, we know, again, this is a big issue that needs to be combated. And we're suggesting that the primary care setting could be the perfect place to do that. And we want to have doctors involved, and they can use, things like motivational interviewing, screening, and brief interventions to help get persons who may otherwise not be interested in seeking treatment just yet, maybe start to consider the possibility. But we will need to make sure that they have the necessary training to make that a reality. So we want to introduce those into our primary care settings, but train up our medical staff to make sure they can do it. And to tackle our lack of knowledge about treatment options at the national level, we can infuse this into that public education campaign I spoke about. You know, we can put posts and run ads and so on, so persons can become aware of the treatment options that are out there. But we also need to go some of the old school routes. So we can do things at health fairs. We may do some seminars. And then we can also use online marketing techniques. So things like search engine optimization can help us make it easier for persons to find treatment centers through online searches and so on. And so that brings me pretty much to the end. And what I would have shown you today is that women, certainly in Barbados, we face various barriers here, which can prevent the women from seeking or completing treatment. And most of them are external in nature. So that means that we could be, we can more easily address them by policy and programming initiatives. While the internal ones may be more difficult to tackle, that doesn't mean that we can't address them. So we can, start with some of what was proposed here. And overall, this study actually is very useful in terms of guiding policy and programming. And because we want to increase the uptake of treatment and retention in treatment for women on island, because this is critical, because for treatment to be successful and have a substantial public health impact, it has to be accessed and it has to be utilized by the women. So that's my parting thoughts. And that brings me to the end.
Mille merci Laura, c'est fantastique de nous avoir fait cette présentation en live. On a été un peu pressé par le temps à cause de la question technique et on n'aura pas le temps de prendre des réactions maintenant. Je vais repasser la parole à Sarah pour embrayer sur le groupe suivant en vous remerciant encore tous et toutes d'avoir été là ce matin ou cet après-midi. À très bientôt. Merci Sarah, merci José-Louis, merci tout le monde.
Yes, thank you, Dr. Priest, and thank you, Laura, for jumping in on the fly to our interpretation team. If you wouldn't mind pausing the recording and running the drill, and then I'll hop in and do an abbreviated through these. Perfect. Welcome to the August session of Subworking Group 3.3. This is our final Subworking Group meeting before we come back together for the larger working groups in September. We can go to the next slide. Perfect. The first thing we want to say is just give a big thank you to our co-chairs, Giovanna Calderon and Justice Teddy, for all of their work over the past 11 months. It has been lots of work, and we really appreciate all your time and effort in moving this forward. Second, we want to thank our international organization coordinators, Anya Bus, Jose Luis Vasquez, Elisa Rubini. We would not also be able to do this without you in terms of identifying speakers, organizing the calls, etc. Y'all, we really appreciate you. The theme today for this meeting is monitoring, evaluation, and transitioning for stability, because now that we're coming up to the 1-year mark of the coalition and moving into year 2, we are in a new phase that needs to be more manageable and easier to organize. And so for the second year, we're measuring success by outcomes, measurable successes. What are we actually getting to? How are we moving forward? Next slide, please. So just looking back, as we all remember, 1 year ago, well, over a year ago now in July,
I am so sorry to interrupt, but we have no interpretation on some of the channels. Hold on 1 second. You have
Sure thing, no problem.
Just a second, please. May I have someone on the Spanish channel talk to me? Okay. Arabic now, please. Thank you. Okay. Portuguese, please. Okay, obrigada. Obrigada. French, please. Thank you. It's back.
Wonderful. Shall I continue?
Please, Sarah. Thank you so much. Sorry about that.
Yeah. So, yes, we had the ministerial meeting that really demonstrated the high level of political will, and look at where we're at now. 1,600 participants from governments from over 100 or from 158 countries with international organizations. And thing two, over 11 months, 148 hours of virtual meetings and dialogue with seven languages so we can all discuss and understand the problem. So we remember in May, we identified the 68 recommended areas of work, and international organizations compiled 120 initiatives to enact those recommendations. And then we have those in-person meetings with the data group in Italy and with our co-chairs in Greece, where we really recognize that we're going to have to continue collaborating, coordinating, and working together to address the intensity and the scope of this work. Next slide, please. But yes, the final thing is we built the car over the last year, and now it's time to drive it. And so we've already gotten started. As we mentioned last month, in Greece, we launched the Global Recovery Network, the Global Women's Network, and the International Consortium for Alternatives to Incarceration. And coming up, we'll be launching the International Network for Legislators on Drugs to identify policy gaps that we've been identifying. And there's also been a sense of just increased coordination overall. We've received numerous country reports that outline all of the different actions that have been taken in other countries outside or within the coalition. And overall, just raising the profile of the issue. But now what we need to do is we need to operationalize actions and initiatives. And so there's different pathways of doing this over the next year. One is through collective meetings as a coalition overall. One idea is having a donors conference to identify gaps in support and coordinate also where we're already contributing and where more contributions are needed. Another thought in the next year is to host a thought leaders conference to gather academia, policy experts, technical experts to really forecast where the field is moving and be proactive in taking action. And any recommendations on hosting other collective coalition meetings, please, we welcome and would love to collaborate with you. Additionally, there are a variety of regional meetings going on throughout the next year, whether the Middle East Dialogue, drug demand reduction and drug supply reduction focal point meetings. We will be having a calendar up on the website that we will be sending out shortly where everyone can kind of see what's going on. And then also in just terms of lines of action, we can pull up the whole thing, and we're looking for groups. If you're focused on one line of effort or the other, we're looking to kind of plan out how to have smaller groups focused on targeted specific issues rather than the thematic groups we are looking at overall. So I'm just going to give one example of the legislative network. So what a year might look like. In October, the UNODC and OAS are launching, and okay, I thought Anne was saying go quicker. But yes, in December, there might be an in-person meeting to identify priorities or certain legislation, and people can bring together different samples, and then looking at the end of how many laws have been approved, enacted, and then at the end of how much stronger is our political or our legislative structure overall worldwide. So that was super brief, but I want to leave more time for our presentations today. So I will end there and thank you all so much. If you want to hear the long version, we will have the recordings of these administrative announcements on the website. But for now, I am going to open it up to our co-chairs to say hello and provide some opening remarks. We have Giovanna or Justice Henderson on the phone.
Muy buen día, Sara. Qué gusto saludarte. Muchas gracias por esta introducción y muy buen día para todos y todas y buenas tardes también para quienes están ya del otro lado del continente. Es un gusto compartir nuevamente con ustedes. Extendemos un saludo también de parte del juez Henderson y copresidente de este grupo junto con mi persona. Sara nos ha hecho un resumen de cómo estamos en el grupo y creo que sin más, para aprovechar el tiempo, vamos a dar inicio con la primera conferencia que tenemos programada para esta sesión, que está a cargo del profesor Roger Peters, profesor emérito y becario de Fulbright, Universidad del Sur de California, de Florida, vicepresidente de ICU desde Consejo de Directores de ICATI, Estados Unidos, y tenemos para ello una grabación que en este momento iniciaremos para que todos y todas podamos escuchar la experiencia.
And welcome everyone. I'm glad to represent ICADI and the leadership team, including the global lead, Michelle Robiek, Melody Heaps, and Jack Charlier. As you probably know, and from Brian's comments, ICADI was launched just recently at the United Nations Commission on Narcotics Drugs in March 2024. And it's a project of the Colombo Plan with support from the US Department of State, INL. So we're very glad to be part of the Global Coalition. This is a priority initiative of the Global Coalition, and we support the activities of the working groups. I just want to mention briefly that ICADI has been discussed in previous 3.3 meetings.
Perdón, Sara, no sé si nos puedes ayudar, o Elisa, porque no estamos teniendo traducción en el canal de español. No sé si en los otros idiomas. Muchísimas gracias. No sé si podemos iniciar la grabación. Muchas gracias.
On each of these activities that we're engaged in, but very briefly, you'll see exploration and development, including training, technical assistance, evaluation monitoring is an important part of the work that we do in helping countries to implement ATI initiatives. Providing resources, our recent webinar series would be an example. We're also in the process of developing a UTC curriculum on treatment in the justice system. And finally, network building, regional and global networks to share information, to learn from one another, including advanced ATI sites that may be doing things that others would be interested in. So we talked in the sub-working group 3.3 throughout the past several months about many types of alternatives to incarceration that we've highlighted and talked about and discussed, and we've had experts from throughout the world talk about each of these. I think monitoring and evaluation strategies and the outcome measures that accompany these may vary according to the type of ATI program. And these are just some examples here. But for example, law enforcement deflection or pre-arrest types of initiatives would look at the number of arrests that are actually prevented by the program. Each of the other types of ATI initiatives would have some similar types of metrics of outcome measures as well. And we'll look at these in just a minute. But again, these are just examples of some of the types of ATI initiatives that we've explored in the working group 3.3 throughout the past year. One thing that's not on here, but actually strengthens ATIs at every point in the criminal justice system is case care management. What are the goals of ATI, and how does this affect the outcome measures that we would like to implement? I won't go into great detail on all of these, but the ATI outcome evaluation measures, as you'll see, flow from each of these types of goals of the ATI initiatives. For example, reduce prison overcrowding. This is a significant problem in most of our countries, and we can actually achieve considerable cost savings if we can prevent construction of jails and prisons. And so this can be a very important outcome measure to achieve cost savings through our ATI programs. Expanding treatment infrastructure and engaging participants in treatment. Some of the early ATI activities across the spectrum in the criminal justice system may include identifying the number of people in different justice settings who need drug treatment, and thereby providing a rationale for expanding treatment resources for our ATI programs. And you can see some of the other types of goals, of course, reducing substance use, reintegration, recovery supports, and improving public health outcomes, including reducing HIV/AIDS, reducing overdoses, reducing overdose deaths and hospitalizations. This might look a bit complicated, but it's not really. This is just a logic model that describes the ATI evaluation process. Basically, if we identify the right set of ATI participants, we engage them in evidence-based treatment. This will lead to positive outcomes, both in terms of behavioral health, substance use reduction, for example, ability to work, contribute to communities, enhanced mental health functioning, reduction of other health problems. These are some of the behavioral health outcomes, but also leading to positive outcomes related to public safety, including reductions in arrest, conviction, incarceration, and reducing the rapid cycling that we oftentimes see with this population of individuals who are mostly untreated in the criminal justice system for their drug disorders. I want to talk just for a minute about the importance of ATI evaluation and monitoring. I think there are many different reasons why we need to conduct ATI evaluation and monitoring. And in my experience, oftentimes this is an afterthought for our programs. And unfortunately, we need data and we need outcomes about our programs fairly soon after implementation, because there are many people who are doubting the quality and the effectiveness of ATI initiatives. And so by the end of year one, maybe year two, people are going to be asking, what are the outcomes of your program? And do they justify the amount of funding that we're providing? So I think there are a range of different types of reasons why we provide ATI evaluation and monitoring. One is just to describe the evaluation, or the ATI implementation process. So basically what's going on within an ATI program that might help explain the outcomes that we're going to observe. What needs to be modified within an ATI program? What adjustments need to be made that we might observe and see during the course of implementation? But clearly, monitoring short and long-term outcomes is a key feature that we need to incorporate in all of our ATI initiatives. We need an ATI program evaluation database to gather data within each ATI program to look at the outcomes of both short and long term. We need a process for collecting and analyzing data from our programs. And we want to be able to share results with funders and policymakers. And this could be brief reports at different time periods, 6 months, 12 months, 18 months, 24 months after implementation. We also see that case studies are important in persuading our funders and policymakers about the importance of our ATI programs. So demonstrating individuals who have benefited from the ATI programs are now contributing positively to the community. Very important. One of the most important features of ATI evaluation monitoring is to justify ongoing funding for our programs. I mentioned this before, but we certainly need outcome data to justify the need to sustain our programs. And we're not going to get a free pass to simply go on forward with our ATI programs without the data to show that these actually work. People are going to be asking these questions and rightfully needing to have some type of outcomes to show what's happening with the ATI programs. Finally, I want to mention that an important purpose of ATI evaluation monitoring is to contribute to our knowledge about what works with alternatives to incarceration, what doesn't work with these programs, what types of things are actually counterproductive, what types of alternative to incarceration programs are the most effective, where we can get the best outcomes and the best return on our investment in these programs. And then finally, another area that we need data and outcome information is how do our ATI outcomes vary by participant characteristics? For example, by gender and a history of trauma. What types of interventions work best for this population? Persons with co-occurring mental disorders, other types of populations as well, youthful offenders. So lots of different reasons to pursue evaluation in our alternative to incarceration programs. Here are just some of the measures that we've developed over the course of the past several years, and these are quantitative measures. You'll see Lisa Rubini and myself have worked on a project with OAS CCAD, with the State Department, and these are not unusual. They're not rocket science. These are not things that you haven't seen before, but I think there are a common set of quantitative evaluation measures that we can consider for each of our ATI programs. I won't go through all of these, but certainly important just to know the number of people who are enrolled in our programs, and maybe more importantly, the number diverted from incarceration or arrest. I think this can be a very persuasive measure, looking at the completion status and reduced substance use. Certainly, reduced arrest and incarceration is a very persuasive type of outcome measure for our funders and our policymakers. And I mentioned before the issue of prison overcrowding. I haven't seen a country yet that we work with who are interested in developing ATIs that prison overcrowding isn't a major issue. And so again, cost savings, perhaps the most persuasive to funders and policymakers that come from not having to build new prisons and jails, for example. Very important measures. There are also qualitative measures that we need to consider and implement in our ATI evaluations. This includes what is inside the black box. What are the main features, the operational features of our ATI initiatives? What are some of the policy and statutory changes, administrative changes that have occurred that have allowed the ATI program to succeed? Are there new funding sources that have been created to expand the resources, for example, for treatment infrastructure within our ATI programs? And what about the capacity for treatment over time? Has this increased? This can be a persuasive outcome as well. And then finally, systemically, looking at improvements to the criminal justice system and the health and treatment system due to ATIs. One of the things that we see very often, for example, is better collaboration between systems that haven't traditionally worked together, the justice system and the health and treatment system. So through ATIs, it could be a drug court or reentry program, a pre-sentence or post-sentence diversion to treatment program. Through any of these initiatives, we see better collaboration, teamwork, partnership between these systems that have often worked in either in opposition or not in isolation. And so this can be an important outcome as well. What are some of the strategies in closing that we're looking at within ICATI and our partner organizations and planning to pursue to increase and enhance ATI evaluation throughout the world? First, we might look at the ATI policymaker training that's been developed and follow-up activities. This is a UTC course, actually, that's been developed, a 2.5-day training for policymakers that has been implemented in different countries throughout the world and includes action planning to develop and implement ATIs in different settings. Oftentimes, this policymaker training leads to a pilot project that's developed in a particular training in a particular area of the country. Evaluation toolkits and monographs are an important piece because we want to share our learning. We want to share some of these common metrics, how to develop databases, for example, in our ATI programs. So basically how to implement evaluation of alternatives to incarceration. There have been several of these developed. CCAD OAS has developed one on drug courts. And I think you're going to hear from Elisa Rubini later in this session describing some of the findings from that particular monograph. A third area that we're looking at is networking opportunities and other resources as well to convene groups that are interested in different types of ATI programs throughout the world. Also, the ICATI website will provide a conduit to disseminate ATI resources and to build the networks in collaboration with ISIP, UNODC, CCAD OAS, the Colombo Plan, and certainly the State Department, INL. Finally, ICATI will be working, again, in partnership with our international organizations to help implement ATI evaluation and to develop protocols, including evaluation databases for countries and regions within countries, localities within countries that are interested in developing ATIs. So we're really looking forward to working with you. Please join our ICATI network, go to the ICATI website, and we look forward to working with you and supporting you in your efforts to develop ATI evaluations. Thank you very much.
Agradecemos a George por su, perdón, a Roger por su exposición y sin duda se coincide totalmente con la importancia de la evaluación. Si no medimos, no vamos a existir en resultados, en justificación de fondos, en poder hacer ajustes para la mejora continua, incluso en la especialización, como nos decía Roger, en cuanto a tema de atención de mujeres o personas menores de edad o personas con alguna condición de vulnerabilidad específica, y por lo tanto la importancia de contar con esas bases de datos que nos permitan hacer el análisis para poder mostrar que las alternativas al encarcelamiento sí funcionan y contribuyen en esta gran lucha contra las drogas sintéticas. Incluso me permito mencionarles que durante el proceso para la aprobación de lo que fue la Ley de Justicia Restaurativa en Costa Rica, una de las bases y fundamentos que permitieron a los legisladores dar su apoyo fue precisamente el que se pudieron mostrar los resultados de estas alternativas al encarcelamiento y cómo contribuyen al bienestar del país. Entonces, sin duda, tenemos que pensar que en cualquier programa o desarrollo de acciones que vayamos a realizar, debemos de visualizar ese monitoreo y esa evaluación. A continuación, damos paso a la segunda intervención a cargo de Donald Wedenberg, del Centro Nacional de Investigación sobre Drogas y Alcohol de la Universidad de Gales del Sur, Sydney, Australia. Entonces, vamos a poner la grabación del profesor que tan amablemente nos ha facilitado.
Hello, my name is Don Weatherburn. I'm here to give you a brief overview of monitoring and evaluating drug diversion programs. Let's start with some basics. What's the difference between monitoring and evaluation? Well, monitoring is purely descriptive. It deals with questions such as how many alcohol and other drug users completed their program, or how many alcohol and other drug users sought access to the program. Outcome evaluation, by contrast, looks at cause and effect. It asks questions such as, did the program reduce illicit drug use? Did the program reduce the number of prosecutions for drug-related crime? There are two key concepts in evaluation: internal validity, which is the degree to which the results of the program are attributable to the policy or program or not to some other factor or set of factors, and external validity. This is the extent to which the results of a study can be generalized to other persons or circumstances or places. There are threats to validity on both counts. The key threats to internal validity are omitted variable bias, sometimes referred to as confounding, and endogeneity. This is reverse causation. I'll explain that a bit more somewhat later. There are key threats to external validity. They are unrepresentative samples and context dependence. Sometimes a program that works well in one context doesn't work at all well in another. The key thing to remember about outcome evaluation is that all outcome evaluations seek to create a counterfactual. A counterfactual is a situation in which we can infer what would have happened had the policy or program not been introduced. There are 6 ways to create a counterfactual: a randomized controlled trials, matching studies, difference in differences, interrupted time series, regression discontinuity, and instrumental variables. I'm going to give you an example of each and try to describe the underlying logic behind them. In randomized controlled trials, you take a large group of subjects, you randomly allocate them to treatment and control groups. The randomization ensures that the comparison group is identical in every way except for receiving treatment. You then apply the program or policy to the treatment group, not the control group, and the effective treatment is measured as the difference in outcomes between treatment and control groups. An example is the New South Wales Drug Court evaluation. Prospective offenders in that program were sent to the drug court for eligibility assessment. There were always more eligible offenders than places on the program, so the drug court held a random ballot to determine which eligible offenders entered the program. Those who were unsuccessful were dealt with in the normal way, that is to say, in most cases they were imprisoned. Here's a piece of evidence from the evaluation. On the vertical axis, you've got the percentage of people surviving, that is to say, who haven't yet reoffended. On the horizontal axis, you've got days since treatment or days since the intervention. The top curve shows the survival rate of people in the treatment group. The bottom curve shows the survival rate of people in the control group. And you can see at once that there are more people who haven't reoffended in the treatment group than there are of people in the control group. The RCT has its strengths and weaknesses. Its strengths are that it's the best method for dealing with selection bias and it's simple to analyze and interpret. Its weaknesses are sometimes it's just not ethical to run an RCT. Treatment dilution's a problem. Lots of people don't complete their treatment programs, and they, generally speaking, have smaller benefits than those who do complete. And when the two groups of people are mixed, you get a dilution of the overall effectiveness of treatment. There are sometimes adverse reactions to randomization. Not everybody likes to be in the control group. And generally speaking, RCTs are invasive and costly to set up. Another option is the match comparison. Here we identify a group of individuals exposed to some program, policy or intervention. We match them on a number of dimensions with another group of individuals not exposed to the program. That's the comparison group. We then compare outcomes between individuals in the two groups. An example is the MERIT program. The MERIT evaluation involves, otherwise known as the Magistrate's Early Referral into Treatment program, is an alcohol and other drug treatment program for defendants in the local court. It's available to those people before they actually plea. The aim of the program is to reduce the harms associated with alcohol and other drug use, improve the health and well-being of defendants, and reduce their offending. Here's a snapshot of evidence from that program. On the left-hand panel, you've got the percentage reoffending within 1 year, and you can see immediately that the reoffending rate in the MERIT group is smaller than that in the comparison group. On the right-hand side, you've got the percentage or the fraction, I should say, who are imprisoned, and you can see that the comparison group has a much higher proportion ending up in prison than the MERIT group. Matching has strengths and weaknesses. It avoids ethical problems and avoids the adverse effects of randomization. It's simple to understand and interpret. Its weaknesses are that there's always a potential for omitted variable bias. It's always possible some factor you didn't measure and match on is responsible for the difference in outcomes you observe between treatment and control groups. You can't always match. It sometimes happens that everybody who's eligible for a program gets onto it. In that case, you don't have a comparison group. And generally speaking, you need very large samples to make the matching effective. Difference in difference involves identifying, for example, an area where residents are exposed to some policy, program or intervention. We call it G1. Identify a second area where residents are not exposed to the program, policy or intervention. We'll call that G2. We take measurements of the target outcome in G1 before and after exposure to the policy or program, and we repeat that process for G2. And then we compare the change in the target outcome in G1 to the change in the target outcome in G2. Let's have a look at a diagram. Here what you see on the vertical axis is some outcome such as reoffending or entry into treatment. On the x-axis you've got the situation before treatment and the situation after treatment. You'll notice I've drawn it so that the control group and the treatment group, so G1 and G2, have exactly the same trend before the intervention. That turns out to be critical. Then the intervention occurs, and I've drawn it so that after the intervention, the treatment group shows a downward acceleration in the adverse outcome. And you can see as a result that the difference between the treatment and control groups post-treatment, as measured by D2, is larger than the difference pre-treatment, that's D1. And that would be an indication that the program's had an effect. If there had been no difference between D1 and D2, you would have said there'd been no effect. Here's an example, the Oregon decriminalization experiment. Noel Spencer wanted to examine a policy change in Oregon in February 2021 that decriminalized small amounts of drugs. He compared the change in unintentional drug overdose deaths in Oregon compared with a control group of other US states. And what he found was that the change in Oregon was associated with an additional 182 unintended overdose deaths, representing a 23% increase in the expected number. Here's a graph showing the results. And you can see that the treatment and comparison group, that's called synthetic Oregon, are identical in the lead up to the change in policy. And then after the change in policy, you can see that the overdose rate per 100,000 of population is higher in the Oregon area than it is in the synthetic Oregon area. Strengths and weaknesses for difference in difference. Well, you've got complete control over all time constant differences between treatment and comparison groups. The method deals with the problem of pre-existing trends, and it's ideal when you're comparing outcome trends in different areas, although you can use the same method to look at differences between groups. Its weaknesses are that the assumption of parallel trends is not testable. You can certainly check to see that they're parallel before the intervention, but the whole method depends on the assumption that if there had been no treatment, those trends would have continued to be parallel, and you can't test that. Autocorrelation is sometimes a problem, but that's a technical issue I won't go into here. Time series analysis. The idea here is to construct a time series of the outcome of interest in the location where the intervention is to take place, include a variable which measures the change in slope or a change in level of the outcome after the intervention, and then run the model to see whether either of the terms reflecting those changes are statistically significant. Once again, a diagram will help. Here you see I've set it up so that you've got a downward trend in the outcome before the intervention. Then after the intervention, two things happened. There's a sudden change in level from Y1 to Y2. But if you look at the slope in the post period for the outcome, you'll see that it's dropping more rapidly. There's an acceleration of the downward trend compared with the slope before. Well, that's very stylized. Let's look at a real example. The New South Wales lockout law occurred when the New South Wales government required all hotels, registered clubs, karaoke bars and nightclubs to refuse entry to new guests after 1:30 a.m. and cease serving alcohol altogether after 3 a.m. The policy was introduced because there was such concern about alcohol-related violence. Here are the results. Looking on the left-hand side, you've got the situation for the Central Business District. This is a plot of the trend in crime, trend in assaults. And you can see after the intervention, there's a rapid acceleration of the downward trend in assaults in the CBD. If you look on the right-hand side, this is King's Cross, and you'll see that although there was a bit of a bumpy downward trend prior to the intervention, straight after the intervention, there was an immediate drop. That's a drop in level. Time series analysis has its problems. Its strengths are that it's ideal where the outcome is a change over time in some frequently measured variable such as crime. It can control for pre-existing trends or seasonal effects. It's highly demanding of data. You need usually at least 60 time points, weeks, months, or years to set up the model. It's not ideal for intervention effects that are spread out over time. And there's always a potential for omitted variable bias if some factor that occurs to influence, for example, assault rates at exactly the same time as the policy occurs. An example might be lots of publicity surrounding the policy intervention. Regression discontinuity is another option. That's applicable in cases where program eligibility is determined by a cutoff on some well-defined scale, such as age or time. The idea is you take a sample of individuals immediately below and immediately above the cutoff and compare outcomes in cases on either side of the cutoff, but close to it. Here's a mocked up example. Suppose, for example, you're interested in whether or not there's a drop in offending as children reach their 18th birthday and have to go into the adult court. You can see that the way I've drawn up, you've got a higher level of offending in the children's court, and there's an immediate drop down straight after they turn 18 and they go to the adult court. That, of course, is not what actually happens. I just use that to illustrate the approach. Here's an example drawn from the real world, the Texas experiment. In some US state courts, judges can defer sentencing to see how an offender behaves. This is similar to what in Australia you call a Griffiths bond. In 2007, Texas put forward a jail expansion proposition, but it was voted down on November the 6th that year. The courts responded to that and the jail overcrowding by increasing the number of people whose sentence they deferred. And the interesting question is whether this increased or reduced offending rates. So here's the situation. On the left-hand side, you've got the trend in court deferral discontinuity. You can see that it was going along until November the 2021 at a lower level, and suddenly there was a jump in the number of people who were deferred for sentence. On the right-hand side, you've got the felony reconviction rate over exactly the same time period. And you can see it immediately that once the increase in deferral started, the reoffending rate dropped dramatically. Regression discontinuity, like the other methods, have strengths and weaknesses. It's great where there's a distinct cutoff point where a policy kicks in or a program commences. It's useful where randomization is unethical for some reason, but it's less powerful than randomized controlled trial designs, and it's of limited generalizability. Generally speaking, the results can only be generalized to people who are in the same position of being either slightly above or slightly below the cutoff. The last method I'm going to talk about is called instrumental variables, and it's specifically designed to deal with the problem of endogeneity. An example of endogeneity would be if you're talking about the relationship between diversion and reoffending. You expect diversion to have an effect on reoffending, but the rate of reoffending is one of the factors people take into account when deciding whether to divert someone, and these two effects can be very difficult to separate. So what's the solution? Well, the solution is to find a factor, commonly known as an instrument, that influences entry into treatment, but which has no effect on the outcome other than through the program, and then exploit that factor to remove the effective selection bias on program outcomes. Let's have a look. So here's your situation. You've got a program manager wanting to impose a diversion program on the assumption that this will reduce reoffending, reduce crime. But the trouble is that he or she's been instructed not to place serious repeat offenders on the program. Straight away, you've got this hopeless confounding between who gets on the program and the effect of the program on reoffending. What's the solution? Well, here's one. You find a factor such as increased health insurance, which increases the rate of entry into treatment. You don't expect it to have any direct effect on crime, but you do expect it to affect crime via its effect on increased treatment. Let's see a real example. Wen et al. In 2017 wanted to test if expanding drug treatment reduced crime, and to do that they exploited the expansion of Medicaid for low-income families and those with a substance abuse disorder, otherwise known as SUD. They assumed that health insurance shouldn't have any direct effect on crime other than through increased access to drug treatment for people with SUDs. Well, as a result, access to SUD treatment certainly did increase, and they ended up concluding on the basis of their results that a 10% increase in the SUD treatment rate can reduce the rate of robbery by 3%, the rate of aggravated assault by 6 to 7%, and the larceny rate by 3%. Their overall conclusion was that a 10% increase in the SUD treatment rate at an average cost of 1.6 billion yields a crime reduction benefit of between 2.9 billion and 5.1 billion. What are the strengths and weaknesses of this method? Well, the strengths are that it avoids treatment dilution, it avoids adverse reactions to randomization, and it avoids ethical problems. Its biggest weakness is that it's hard to find convincing and strong instruments, and also it's got low statistical power, so you want to have a large sample size to get the best benefit out of an instrumental variable method. Well, that's it from me. Here's the further reading if you're interested. Thank you very much for listening.
Agradecemos al profesor Donald por darnos un panorama desde la teoría y la parte conceptual de lo que es evaluación y monitoreo, los diferentes tipos de metodologías que se pueden utilizar, pero el profesor va más allá y nos permite de una vez observar cómo cada una de esas cómo cada uno de esos tipos de evaluación se han puesto en práctica y nos muestra resultados de estudios realizados en la vida real, y de ahí derivamos que efectivamente la alternativa al encarcelamiento, el aumentar el tratamiento, nos va a ayudar a reducir la criminalidad y todo lo que trae en consecuencia ello para la sociedad. De esta forma damos paso a la última intervención que tenemos para esta sesión, que está a cargo de la doctora Catalina Droppelman, directora ejecutiva del Centro de Justicia y Sociedad de la Universidad Católica de Chile, quien también nos ha facilitado una grabación, y a continuación procedemos a escucharla.
Hola a todas y a todos, mi nombre es Catalina Droppelman, soy directora del Centro de Estudios Justicia y Sociedad de la Pontificia Universidad Católica. Hoy día vamos a conversar acerca de algunos elementos clave y desafíos en la evaluación de los programas de justicia terapéutica. Lo primero que vamos a revisar, y en lo que va a estar centrada esta presentación, es en cómo definimos el éxito del programa. Y acá tenemos básicamente tres conceptos o tres maneras de operacionalizar nuestros resultados, nuestro outcome o nuestra variable dependiente. Lo primero tiene que ver con la reincidencia, es decir, la reiteración de la conducta delictual. Nuestros programas de tribunales de tratamiento de droga o de justicia terapéutica tendrían que disminuir
deteniendo la
o
grabación
evitar
para
la
poder
reincidencia
escuchar a
tras el
Connie.
ingreso del programa. Un segundo
Gracias, Sara.
un resultado legal tiene que ver con cumplir el castigo, ¿no es cierto? Con disminuir la reincidencia y con favorecer la abstinencia, especialmente en aquellos lugares donde el consumo de droga está criminalizado. Pero por otro lado, un resultado terapéutico tiene que ver con eliminar o reducir incluso, ni siquiera eliminar el consumo de droga, pero también en generar mejoras en la salud y en el funcionamiento psicosocial. ¿Ya? Esto no necesariamente va unido, no es consecuencia el uno del otro. Uno puede tener, por ejemplo, una disminución de la reincidencia, pero no observar ciertas mejoras en la salud o en el funcionamiento psicosocial. Entonces, cuando uno refiere o piensa cuáles de estos resultados son los que vamos a priorizar, a veces incluso puede llegar a pasar que estos resultados se pueden llegar a contraponer. Por ejemplo, veamos el tema del cumplimiento. El cumplimiento no es equivalente a la motivación. Existen varios estudios que dan cuenta de personas que cumplen los programas, que participan, que van a todas las sesiones, que hacen todo lo que se les mandató hacer, pero que no necesariamente experimentan un cambio. ¿Y esto por qué ocurre? Porque los procesos de cambio en el largo plazo, los procesos de abandono del consumo de droga, los procesos de desistimiento, de abandono de la conducta delictual, tienen que ver en gran medida con la motivación al cambio. ¿Ya? Entonces, cumplir no implica desistir, cumplir no implica un proceso de abandono del delito. Y acá tenemos el modelo de Anthony Bottoms que plantea tres niveles de cumplimiento. El primer nivel de cumplimiento es uno instrumental, donde las personas generan cambios conductuales, pero en general en el corto plazo o de manera muy instrumental o formal, por mecanismos de refuerzo, de sanciones o de incentivos. ¿Ya? Existen otras maneras de cumplir también con una sanción, por ejemplo, que es una manera que se denomina situacional. Y eso tiene que ver con restricciones ambientales. Por ejemplo, simplemente por estar privado de libertad, tú estás cumpliendo, ¿ya? Pero ese cambio conductual no se va a mantener cuando esa persona, por ejemplo, salga en libertad. Entonces, existe otro nivel de cambio a largo plazo, más sustantivo, que es lo que se busca a través de la justicia terapéutica y que tiene que ver con un cambio a nivel normativo, que ocurre cuando se internaliza la norma, cuando se producen procesos de cambio por mecanismos también de control social informal de otros significativos que esperan que la persona cambie o que coayudan en los procesos de cambio, pero también por los procesos de legitimidad. Es decir, cuando las personas legitiman la norma, legitiman una sanción, existen mayores probabilidades de que generen un cambio más profundo, un cambio a nivel normativo. ¿Ya? Por ejemplo, la evidencia da cuenta que muchas veces las personas que tienen cambios instrumentales, es decir, que cumplen con el programa, que van a todas las sesiones, que van a todas las audiencias de seguimiento, 48% de ellos retoman el tratamiento de rehabilitación de drogas al año. ¿Ya? Es decir, este cambio más bien instrumental no se mantiene a lo largo del tiempo. Por lo tanto, es este tercer nivel de cambio el que nosotros queremos fomentar. Otro elemento importante a considerar tiene que ver también con la idea de la reincidencia, ¿ya? Y cómo nosotros realmente definimos que alguien cambió. ¿Cómo se genera eso? El cambio, el abandono de la conducta delictual no ocurre de un día para otro. Las personas no despiertan un día a la mañana y dicen voy a dejar de delinquir y lo cumplen. En general los procesos de abandono de la conducta delictual toman tiempo. Tienen idas y venidas, tienen también recaídas, al igual que el abandono del consumo problemático de drogas, ¿ya? El tiempo de seguimiento también es clave. Las personas tienen intermitencia muchas veces en su consumo problemático de droga y también en la conducta delictual. Nosotros podemos seguir a alguien un año, pero si alargamos el periodo de seguimiento a 2 años, a 3 años, muchas veces sí vamos a observar reincidencia. Por lo tanto, el concepto de reincidencia también está limitado por el periodo de observación, ¿ya? Y otro elemento importante tiene que ver con los datos que nosotros ocupamos para medir la reincidencia. Es decir, ¿vamos a ocupar datos oficiales o vamos a ocupar autorreporte? La evidencia da cuenta que de cada 2 datos oficiales, por ejemplo, de arrestos, existen 100 delitos autorreportados. Nosotros tendemos a creer que el autorreporte genera sesgo, pero en general el autorreporte es más efectivo muchas veces que los datos oficiales, porque los datos oficiales sufren de la cifra negra, es decir, de todo aquello que no se pesquisa, que no se reporta, que no se judicializa. Y esta idea también de que el cambio no es necesariamente radical, observamos muchas veces que las personas que delinquen transitan en un espacio liminal entre la delincuencia y la no delincuencia. Entonces también se dan cambios cualitativos en este proceso, que tenemos que ser capaces de pesquisar. Por ejemplo, desaceleramiento, personas que disminuyen la frecuencia de sus delitos. Descalamiento, personas que disminuyen la severidad de sus delitos. Personas que también disminuyen la versatilidad, la variedad de los delitos que cometen, o personas que circunscriben sus delitos a delitos más específicos o que desplazan la conducta delictual incluso hacia otras conductas, ¿ya? Por lo tanto, tenemos que ser muy finos y muy específicos cuando medimos la reincidencia, porque la reincidencia, cuando nosotros la medimos a través de la presencia o la ausencia de delito, como una variable 0,1, una variable dicotómica, perdemos gran cantidad de cambios cualitativos que se dan durante el proceso. En cuanto a la disminución del consumo problemático de droga, lo que hay que preguntarse tiene que ver con que si realmente son las drogas el único conflicto subyacente a la conducta delictual. Y acá, ¿qué es lo que nos dice en general la evidencia? La relación droga-delito se explica en general por un modelo teórico que desarrolló Goldstein en el año 85, donde establece 3 niveles de relación entre el delito y las drogas. El primero es psicofarmacológico, es decir, personas que cometen delitos bajo los efectos de las drogas. Económico-compulsivo, es decir, personas que cometen delitos para proveerse de dinero y con ello comprar droga. Y sistémico, que son todos los delitos que se dan dentro del sistema de distribución de droga. ¿Y acá qué ocurre? Que la correlación, es decir, que la droga y el delito se correlacionen, sean 2 fenómenos que se dan de manera conjunta, no implica causalidad. No sabemos realmente qué causa el consumo de drogas, ni qué causa el delito, ¿ya? Este modelo tripartito de Goldstein también es difícil de testear, y muchos infractores inician el consumo previo a la delincuencia y lo mantienen incluso tras desistir, es decir, no están tan correlacionados como se pensaría, ¿ya? Y también la relación entre droga y delito es altamente sensible si consideramos el contexto cultural, el estilo de vida. Es decir, ambos conductas, tanto el consumo problemático de droga como la delincuencia, tienen causas comunes subyacentes, ¿ya? Pero eso no significa que haya una relación causal entre ambos. Por lo tanto, lo que nosotros no podemos pretender es que al sacar el consumo problemático de droga, inmediatamente vamos a disminuir la conducta delictual, ya que la conducta delictual puede también responder a una serie de otros factores. También tenemos el problema de la equifinalidad y la multifinalidad. ¿Qué quiere decir esto? Que una misma conducta de riesgo puede causar diversas conductas, pero al mismo tiempo una determinada conducta también puede ser causada por múltiples factores de riesgo, ¿ya? Por lo tanto,
I think there might be an issue with the interpretation channel. We just have about a minute left.
es muy difícil desenmarañar la relación causal y poder establecer una real causalidad entre ambos fenómenos que nos permitan realmente asegurar que al eliminar el consumo problemático de drogas vamos a eliminar la reincidencia. Entonces, ¿cuáles son las ideas finales al haber analizado este desafío de cómo medimos realmente el éxito de los programas de tribunales de tratamiento de drogas? Debemos entender qué es lo que causa el impacto en los tribunales de tratamiento de drogas. Y existen otros elementos que causan el impacto, como por ejemplo también la percepción de justicia procedimental, las audiencias periódicas, el acompañamiento judicial, lo sistémico y holístico que es la intervención, que son elementos que también están relacionados con el éxito de estos programas y que también tenemos que ser capaces de medir. Y por otro lado, tenemos que también definir qué entendemos por éxito del programa. Y más allá de lo que yo les comenté hoy, también eso se relaciona con los fines de política pública que su país, su territorio, su comuna busca también al incorporar un programa de este tipo. Espero que haya quedado claro al menos este desafío de cómo medimos el éxito de los tribunales de tratamiento de drogas. Que estén muy bien. Muchas gracias.
Agradecemos a la doctora Catalina y estando en tiempo, trasladamos la palabra a Sara para que pueda cerrar la sesión. Muchísimas gracias de parte de nosotros como copresidentes.
Thank you very much, Giovanna, and thank you to all on the call. We look forward to seeing you in September, and thank you all again. These were wonderful presentations, and we look forward to seeing you in September. Have a good one, y'all. Thank you.